Okay, calling to order the Joint Committee on Ways and Means and the Committee on Health and Human Services. So this morning we're here from the Hawaii Health Systems Corporation, and they'll be presenting their biennial budget request. Good morning. Happy New Year.
Good morning. Good morning, Chair. Good morning, Vice Chair, members of the committee. Good morning, Chair San Bonaventura. Good to see you folks again. My name, for those of you that I think you all know me, but for me, if you forget, my name is Edward Chu. I'm the President and CEO of Hawaii Health Systems Corporation. In my comments this morning, I'll be covering the HHSC region, so HTH 212, and also I'll be covering Oahu region as well, so HTH 215. So just to summarize very quickly our testimony. So, we for those of you that may not know, we are basically the rural healthcare safety net. We also serve disadvantaged populations, and because of that, we have a very important standing in the healthcare community. At this point, we account for about 13% of all the acute care discharges in the state, and also 19% of the emergency department visits in the state. So it's a pretty big percentage, and on the neighbor islands, that percentage grows to the majority. We do, as a system, though, we do face several historical challenges. The first of which is we do serve a large percentage of Medicaid, Quest, and uninsured patients. For government type payers, which includes Medicare, we're at about 74% or 75% in terms of our payer mix. 45% of that is Medicare, about 30% is Medicaid, Quest. So we are serving those that need the care the most. The other part to mention is our labor costs are well above industry norms. As a state agency, we follow the compensation packages and benefit packages of the state. So our fringe benefit rate, as you folks know, is about 64% that we get assessed, and we pay that out of our own pocket. Most private hospitals here in Hawaii pay about 30% for a fringe benefit rate. So the difference between that 30% and our 64% level equates to about $90 million in terms of what our general fund need is every year. So just to point that out. The other thing I wanted to just point out in our challenges is that, we have a significant need for capital investment, particularly in new medical technology. We have plans to invest in an EMR, and that's part of a budget request, which I'll summarize very shortly. But it is starting off at East Hawaii region. They are planning to convert to the Epic medical record system, which is a pretty significant step, because then it would allow them to be on the same platform as the other major hospital systems in the state of Hawaii. So almost all the hospital systems in the state are on Epic. There are a few that are not, but I think that would be a good way to improve the patient access, patient outcomes. So we have a part of the request is in there, and I'll go over that in a few minutes. So just to give some context to the request, and I think I'm on page 4 of our testimony. So during the pandemic period between fiscal year 2020 and fiscal year 2023, we have received significant federal funds. We have provider relief funds of about over $60 million. We have Paycheck Protection Program loans of about $20 million, and we received other federal funds. So if you look at all those funding levels together, that's about $100 million in federal funds that we received during the pandemic period that helped us to kind of defray the costs of our operations during that time. So we didn't have to ask for as much general funds as we normally would have. We realize we are stewards of state funds, so we do not want to ask for more than what we need basically to sustain ourselves for each fiscal year. So because of that, I think our general fund appropriation levels, going into that pandemic period and also extending into even this current fiscal year, are lower than what we probably would have needed had we not had those kind of funds available. So in fiscal year 24 and 25, our general fund appropriations were about $160 million annually for HTH 212. We have requested about $260 million in fiscal year 26 and almost $200 million in fiscal year 27 in general fund appropriations. The governor recommended $151 million approximately each fiscal year. So basically, just to put into context, so throughout the past fiscal years, our general fund appropriations represent about 22.5% of our total operating and non-operating expenses. And if you look at our request, based on our projected expense and non-operating expense levels going into fiscal year 26 and 27, the percentage of general fund appropriations that cover that is about 24% and 22%. So it's around the same level. And that's in spite of the fact that we have we expect significant increases in costs. Insurance costs are going up quite a bit. Pharmaceutical costs continue to rise. Contractor labor costs to meet some of our staffing shortages are expected to increase as well. So because of that, that is a large reason why our general fund appropriation looks very large. The other part of it is there's $13.2 million in fiscal year 26 and about $2.3 million in fiscal year 27 related to costs for the EMR implementation of Epic in East Hawaii region. And that pretty much is to try to build a backbone of EMR system that could support other HHSC regions in the future. There are discussions with other regions in terms of jumping onto the Epic platform that could be supported by East Hawaii, which would be a good thing, I think, for the statewide health system overall. So just that kind of, that 13.2 million is why that fiscal year 26 number looks a little bit bigger than the fiscal year 27 number. Just wanted to move on to Oahu region, HTH 215. So for fiscal year 24 and fiscal year 25, they received 20.1 million fiscal year 2024 in general funds. Fiscal year 2025, about 21.3 million. In their request for fiscal year 26 and fiscal year 27, they requested $8 million in fiscal year 26, $14 million in fiscal year 2027, and the governor recommended that amount. So the governor's in line with that recommendation. And the reason they're able to reduce their request to those levels is because of the acts the legislature did back in 2022, I believe, to increase the Medicaid reimbursement rate for long-term care facilities. So that increased their reimbursements for their long-term care visits by about over 67%. So it was a pretty significant increase for them. And then in terms of our CIP requests, we have several requests that I think your staff has information on in terms of individual items. I'll just point out a few that are pretty significant. One is for the it's listed under Ka'u Hospital, but it is for the Kea'au Benioff Health Center. It's a project that is being funded by that we requested $25 million in CIP funds for, 12.5 million in fiscal year 26 and 12.5 in fiscal year 27. That is being matched by a contribution by Mark and Lynn Benioff of $25 million. So we're asking for the support for the CIP portion of that. And I think that'd be a great benefit to a community that's growing. And if you have ever been out to that area of the Big Island, not a lot of healthcare facilities down in that area. So, and we have an emergency, time is of the essence. The other major request we have that was supported by the governor is for the Kona Community Hospital ER expansion and reconfiguration. That project is going to be especially important. Their ER visits, they're at capacity pretty much every day. If you've ever been there, if a patient comes into the walkways in the emergency room now, everybody has to stand up and squish against the sides. So, you kind of have fat guys like me standing out there and blocking the way. So it's important that we remodel that so that it gives appropriate space for patients to put through the emergency room, and also to become more ADA compliant as well. And the last thing is there is a request in under Kauai region for some EMR capital funds, and there's a placeholder for now. We don't have the exact numbers. It's 7.5 million in fiscal year 26 and 7.5 million in fiscal year 2027, and those funds are for basically for Kauai region to jump onto the Epic platform for East Hawaii and to help pay for those implementation costs of that system. So in that sense, HHSC would pretty much, for our acute facilities, would all be on one system. So and just in summary for everything, and we also have Kahuku Medical Center here, and they'll be presenting on their own budget. We also have Maui Health Systems here, they're presenting on their own budget requests. But I'm hoping that when you folks hear about us in the news or in your local community, that the sense of collaboration that we're trying to develop with other health systems and the community is evident. You've already heard about our Hilo Benioff Medical Center partnership with the Benioffs, with a $50 million contribution there. So we're hoping that to foster that into a long-term, supportive relationship there. And that also brings about collaboration with Hawaii Pacific Health and University of California, San Francisco Medical Center to bring specialists, to bring recruitment help, and also to develop and to improve neurosurgery coverage for the Big Island. So those kind of collaborations I think are important going forward. We've already seen West Hawaii, they've partnered with Queens to get onto the Epic platform, and that's been a benefit to them as well. We also have the Samia Mahelona in Kauai, the master plan there. That's going to be a community project that'll be beyond just healthcare. It goes to housing and other social service agencies that'll benefit from being able to use the land on that campus. And Oahu does several partnerships, one with the Adult Mental Health Division for their Polycana program for substance abuse patients. They also have a core program that they're doing with the city and county of Honolulu and Queens to have a medical respite home for patients that are homeless and have other issues coming out of the emergency rooms. And they also have a partnership with Queens to use some of the space at Malahia to house some of their long-term stay patients. So that offloads some of the waitlist patients at Queens to be able to be in a more appropriate level of care and frees up beds at Queens Medical Center that they badly need. So that's the spirit that we bring to this committee and to our communities every day. And we're hoping that you folks will support us in that endeavor. The tables, our budget briefing tables you have in front of you. I'll just kind of briefly go over what's in table 6 to point out. So you'll see under, well, let me start off with HTH 212 because HTH 211 will be covered by Kahuku Medical Center. But you'll see this. The second line item under table 6 is increase in the general fund appropriation of $67.3 million. That is to add back for the funds that were marked as non-recurring in the budget, primarily to replace the ARPA funds that we had received in prior years. That's about $41 million in ARPA funds that we had received in fiscal years 22 and 23, and also the other general fund increase that we had received in the 24 and 25 time period. So that is one addition. The other one that affects our program IDs are the full Oahu region on the 2, 3, 4th line down for the $8 million, $14 million. I kind of talked about that general fund request already. Because the amounts that provided to Oahu region in the prior biennium were marked as non-recurring, they had to start from a zero base. So that's why the $8 million, $14 million are there. And also the last item there in the Oahu region is to restore their special fund ceiling. That is just to have them so that they're able to spend their cash collections on funding their operational expenditures. So that brings it up to $48.5 million, $48.4 million. I'll be happy to answer any questions.
Members, any questions?
A quick question. When you're opening about the fringe benefit at 64%.
Yes.
I realize that, high across the board. Well, how is it that the private sector fringe is just at 30%?
It's because our state of Hawaii benefit package, because we are a state agency, right, and we follow the same collective bargaining and negotiations and benefit packages that state employees have. So the major difference between state and private is essentially 2 things: the defined benefit pension plan funding that's needed for that. Most private companies have done away with pensions for the most part. They're into like 401k or those kind of programs. So the cost to the employer is much less. The other major portion is retiree health insurance benefit that the state provides. Some of them private hospitals do provide maybe a small amount of retiree health insurance benefit, but it is nowhere near the level that the state of Hawaii provides. So those 2 factors probably account for, I would say, pretty much all the difference between the private hospital fringe rate and the state of Hawaii fringe rate.
Yeah, well, thank you for saying that, because I think the public is not necessarily aware of the differential as we are between the private sector and government and what it is we provide. So thank you.
Thank you for that question. The one other thing I should mention too for HHSC that's a little different from the other state agencies is that, we have been paying this fringe rate out of our own cash collections, basically. So we're trying to fund that as much as possible out of the patient revenues that we generate. Other agencies, those costs are taken care of by State Department of Budget and Finance. So it's a little different for other agencies.
That's why, sometimes they say government salaries are not as high, but the fringe benefits and the benefits that they get, especially healthcare, is huge. So that makes up some of the differences. Thank you.
Thank you. In your report, the Daniel K. Akaka State Veterans Home is being transferred under your jurisdiction?
To the Oahu region, yes.
Yeah. So are you appropriating funds in this biennium for operations? Because it will open up this year, right? Or how does that work?
Want me to answer that, or? Okay, well, I'll just give you the short answer. So essentially the general fund appropriation that Oahu region is seeking is to fund the operations for Leahi and Maluhia. The state veterans home, when it opens, which probably will be, this calendar year sometime, probably in the summer, or maybe if everything goes right earlier, maybe later in the spring. That is going to be funded through, it's being run by a management contract with a company called Ohana Pacific. They run long-term care facilities across the state. They are going to be responsible for funding a lot of the operations. Oahu region does have the ability to fund some of the shortfalls in the short term, but we're not asking for additional funds out of the legislature to fund the veterans home at this point.
Okay, thank you.
Sure.
Thank you, Chair.
Go ahead.
Okay, just looking at your 212 on your regions, you show a abolishment.
Which table is that?
Oh, okay, table 6 that
Oh,
he was
okay.
on. It's on table 6. And there's an abolishment of a position, the procurement and supply. And you abolished that, or it was a vacancy anyway, I guess, on April 1st, 2024. There's an abolishment. So is that, you were just deleting the, okay.
I think it's table 11, yeah? Is that what you're
Yeah,
referring to?
20. Yeah, that's a vacancy report.
It's table 11.
Okay. So with the question, you're abolishing that, but that has to do with the vacancy then. And you replace the position, or where are we with procurement?
You're talking about the senior contract manager position. Is that the one you're referring to? The one third line down?
Well, I'm looking at page 20, 21 on our table 6.
Yeah,
Page
so it's the third,
21.
it's
Yeah,
the third
there's a-
position down,
So my question is, yeah,
Table 11.
table 11.
oh, okay. But anyway, it's showing up on this page, but so we're asking, you're abolishing positions with vacancies. So, but you already have replaced, or how are you accommodating procurement office?
Yeah, so this is just for the corporate office
Okay.
that we're talking about. So it's not a facility, it's not a regional position.
Okay,
We do have, right now we have 2 contract managers at the corporate office, and they feel they're able to handle the workload we have for our system-wide contracts. So we do not feel the need to keep this position open for recruitment any longer. So that's why we're abolishing it.
okay, thank you.
Yeah, so I have a couple of questions. One, you're talking about the partnerships you had with Queens. I thought it was also with Leahi as well as Maluhia, right?
The core program that is on the Leahi campus is Queens is one of the partners involved with that program,
But
with the
also
medical respite.
also long-term care.
That's a Maluhia.
Only Maluhia. No, I thought it's both.
It's both.
It is both. Yeah, okay, and you folks are able to, you folks are able to offload a lot of the Queen's wait list, or,
You should come forward.
yeah, I should come forward.
Okay, so I'll introduce myself. Good morning, chairs, vice chairs. Happy New Year. Sean Sonata, Chief Admin Officer for the Oahu region. To answer your question, Chair, we have programs at both Maluhia and Leahi. I think what you're referring to would be bringing patients in from the Queen's wait list, but also in our collaboration with the Department of Health and the Hawaii State Hospital. We've been able at Leahi Hospital to bring in patients into our long-term care program. So it's not a special program. It's individual contracting with the Department of Health to bring in very low level from us, I guess, mental health acuity, low level, but also incapacitated individuals that could qualify for conditional release or discharge from the Hawaii State Hospital, and we'll bring them into our long-term care facility. That's something that's been ongoing for a long time at Leahi alone. At Maluhia, we're looking at also admitting those types of residents where it's feasible, but primarily we're working with a special program with Queens where we would admit people from the waitlist who also are very incapacitated and can be released from those ER beds or those other waitlisted beds and are more appropriate in the Maluhia long-term care setting. So we're working on that as a special project. The reason why it's called special is because our arrangement with Queens is financial. While they might meet the requirements, the Medicaid process is very complicated, where if we admit someone who doesn't have Medicaid yet, they, we get no funding, right? And so when they get admitted, they're considered Medicaid pending. And we're caring for them, we're expanding all our resources to care for the person until they get qualified. And then down the line, when they get approved, if they get approved, then the funding comes back retroactively. So the way we're operating with Queens is that when we admit a resident who's not qualified for Medicaid, they will front the cost. So we're not taking this initial loss. And then later on down the line, then we can reimburse them when the payments come in. It's just we're not shouldering the risk of a non-approval, because if it's not approved, then there's no funding. But if it is approved, then we're just giving them back the money.
So
that
the
they
Department of Health one, how many? See, I just finished talking to Dr. Fink a few minutes ago.
Okay.
And my understanding was you guys were not taking any Department of Health.
No, that's not correct.
Oh, good.
I,
That's good to hear.
but I'm not gonna dispute what is being said, because it could be a different context, but
Okay.
from the way that I understand it to be, we have been admitting patients from the Hawaii State Hospital into our facilities. We have a record of some that's been admitted over the last, I don't know, several years. Recently, he's correct. We haven't been able to do it because it has to be appropriate for, for our rooms. If we have someone that they might think is fitting for our facility, primarily Leahi at this point in time, but we're gonna put someone like, I'll just say, I'll just give an example. I'm just making this up. A male a patient from Hawaii State Hospital who may have certain outburst tendencies, and then the only space we have at our Leahi facility would be with 3 women, and there's one.
You don't have.
We can't admit in that context, right? Correct. But at any point in time when we have someone that would be appropriate for our facility, we would go ahead and.
Okay, so I'll ask you more about that later on then. Okay,
Absolutely.
about how many. My other question is, you said about, and it's not necessarily with you, it's with HHSC in general. You had partnerships. Do you folks have partnerships with the Cancer Center?
The cancer center?
I see
Hawaii does,
Brickman.
yes.
Because I remember seeing a cancer center and it was with Arthur Anderson before. I'm hoping it's here.
Yeah, I can elaborate some of that. That's
Yes.
Good morning and happy new year, chairs. And
Introduce
senators.
yourself.
Dan Brinkman, I'm the East Hawaii Region CEO for HHSC. Good morning. The question about what we're doing for cancer and so forth, actually, East Hawaii Region or Hilo Benioff Medical Center has been working to become part of the Hawaii Cancer Consortium. So that's that partnership that between, I think right now, the main partners are Queens Health Systems, Hawaii Pacific Health. I think Kaiser has a limited role in there, and of course, the UH Cancer Center, and they basically have a consortium together to provide access for clinical trials for patients. And traditionally, Neighbor Island patients have not been able to get access to clinical trials because there really isn't a relationship. And there have been work through the Cancer Consortium to try to expand to the Neighbor Islands. They do more than just clinical trials, though. They do cancer prevention education. And I think also importantly for us, it's an advantage when it comes to recruitment of oncologists because they generally get an adjunct appointment with the cancer center and the ability to do some level of research or at least have some involvement in clinical trials. Because if you're an oncologist and you're going to go practice on a neighbor island, you're going to go, I'm going to be in the middle of nowhere. Maybe I don't have that professional support and camaraderie. And so we've always struggled to get oncologists. And so by having this relationship, we're able to basically be a more attractive place to practice. Because Hawaii Island is a great place to live. Professionally, though, people do feel distance. So that's kind of what we've been working on.
So when you have this relationship with the cancer center, do the oncologists that they share with you folks, do they get paid by you folks or who pays them?
The center doesn't have oncologists, it's Jobson's or the hospital.
Yes, so the employment, it depends on how you structure the employment relationship. So in general, our medical group will employ the oncologists. They will have an adjunct appointment. So they would be like an assistant professor of human oncology at the University of Hawaii. And they have relationships and connectivity. We bear the cost for that. Now, there are other relationships. Well, if they were actively working as a researcher, the UH would pick up that component of their cost. But generally, we go out and hire people who more practice and they have more of a clinical relationship with research.
It's
We'll-
like
we'll
that,
talk- we'll
it's
talk
like
about
that too, when he gets paid extra to do oncology work, and he's also at the cancer center. But cancer center doesn't have doctors, oncologists, it's two jobs and
All two jobs and then go.
that's why we wanted to combine the two, because they need to have these.
We'll talk. Okay, because they've come up. One other question, sorry. Sure.
Just keep it going.
Okay, I want to talk about the KL Benioff. Have the plans changed from last time? Because my understanding is you guys weren't gonna ask us for more monies because Benioff was gonna put in the entire amount, but apparently not. What's happening?
Um,
Or maybe my understanding was wrong.
Yeah, I'm always careful telling senators their memory was faulty, so.
Okay.
The initial idea to have more healthcare infrastructure in KL has actually been something our board, our regional board is prioritized. So it was supposed to be in more of a phased approach. So there was phase 1, phase 2, and potentially 3, and they were smaller bites. So the initial funding we got was for stage 1. You gave us $4 million to do infrastructure, site, and planning and design. Okay, so that was for the stage 1, which was a more modest price, probably around in the neighborhood of a $20 million investment in infrastructure. We had the idea, and I think it hopefully has paid off, to package together both stages and to go to philanthropy and see if they would be willing to do it all at once and to contribute substantially for that. In the discussions back and forth with the Benioffs, they are very much kind of the mindset that they partner and they help. They put in the entity, the state, or whoever the hospital is that they're working with also contributes, and they wanted to do a matching fund type of arrangement. They never, said, well, if you can't get it, we may be interested, but we really would prefer to have it where the state contributes and we contribute. And I know that he had interactions with the governor. The governor put this in his message with basically an understanding that what the state contributed, they would match. And I think together, 25 and 25 is 50. We have set aside to save some money for the project. We expect it to be around a $60 million, but it does it all at once, which KL certainly needs, Puna needs. It's just, we couldn't afford to do that on our and the state's dime. So that's why we were staging it. But with philanthropy, they like things that have big impact. They don't do incremental. And by putting it together, I think we got a lot of interest from, these major dollar donors to actually get it done.
Okay, so basically same plan except expedited.
Yes, absolutely. It's both stages are all together. So stage 1 and 2, notice the size of the project doubled. It was because we took stage 1 and stage 2, put it together and presented them, did the pit, and they were like, we can do this.
It's ambulatory and behavioral health.
Absolutely. Yeah.
Okay.
All right. Thank you.
Ed, I noticed on table 11, it's about the 1, 2, 3, the 6th line, recruitment ongoing, but that was since September 2019 for Infotech Specialist 5.
Yeah, we are constantly in the process of trying to recruit people for our corporate help desk, which is a place that, if you have problems with your basic IT systems like your desktop or your laptop or anything we run to the network, that people call into, and that's where the first triage level is, I guess, for IT support. So we've been constantly trying to find people to man that position, and that's why this position has been ongoing recruitment. We constantly need
So
more people for that.
You have more than one, or is this one position has just not been filled?
Yeah, we've been able to keep the staff kind of somewhat at a constant level, but we've always had this one position that we always needed one more person for. So despite some of the turnover that we've had, we've managed to fill some, but we still have this one position that we think would be helpful in terms of getting the IT help that's fully staffed.
Okay. So what are you guys gonna do though? Because 6 years.
Yeah, I mean, we've been managing so far with the volume that we've had. As so far
I mean,
throughout the years,
the approach, like you gotta go work with either the community college
Yes.
Department of Labor. I mean, gotta have different strategy.
Right. We've tried different avenues of recruitment for that position. We do reach out to community colleges to see if they have IT specialists that could potentially apply for the position. It is a specialist 5 though, so it's a little higher grade of IT specialist than someone that comes right out of school. So it's a little bit tougher, but so far the regions have been pretty satisfied with the feedback that we've received on the help desk function. So I think we just want to keep it on as in terms of someone that can help manage the load, especially if there's any kind of absences. But
having a lower, I guess a lower specialist number is better than having none.
right, I think, but we also have to look at the capabilities of the person and what
So
kind of
even if you
work
went
that we
down 1 or
handle. So
2 levels,
we
and
constantly look
see-
at these positions and what level we have. We've looked at recently one of our contract specialists in the corporate office. We had it at a senior level, but we've had success in recruiting at lower levels and training them up. So we've taken those approaches as well. And we'll be looking at those kind of positions and also looking at taking a similar kind of approach.
So how many times has this position been out for recruitment?
It's been out there for a while.
Yeah.
Vacancies. So on the vacancies, you have a number of positions that the amounts, as far as budgeted amounts, are blank. Is those had monies before, or they never had monies, or how do you fill them if they're blank?
Yeah, the way HHC does vacancy is a little bit different than the state because with most state agencies, there's funding tied to a specific position. HHSC has position control, so it doesn't quite work the same way. When we do our budgets, we project out the amount of personnel we need to run our operations. Now, currently, some of those functions are being done by, like, on the clinical side, especially, some of those functions are being done by contracted help, like contracted nurses, contracted techs, those kind of personnel. So when we do our budget, we look at what we need. And if we're currently being filled by a contracted person, we'll flip that from a contract. We'll reduce a contract expense and add it into our personnel expense. But the total expenditures are going to be basically about the same. So there may be a lot of areas here where you see budgeted amounts, but there's also some where you don't see any budget amounts, and that's kind of why.
So you've literally taken the money from those positions and used it for another position, basically.
No, we still do the function. The function still needs to be filled. So what we do is, if we can't find, like right now, there's a hard time finding techs. We have a hard time finding CNAs, especially. So if we're able to contract for some of those positions, we contract to help fill those needs. But the money is basically from when we budget, we've had that in salaries expense. But if we can't fill that position, we are able to get the resource, then we put it into contracts.
The positions that don't have money and it's vacant for so long.
If we have a position that is vacant, we don't necessarily fund all of our vacancies in our budget request. So when you look at our numbers, we don't have all of our vacancies built
Understand.
into our numbers.
And that's what I'm trying to get a handle on, because you're not the only one. Throughout the state government, they have hundreds of vacant positions with no money. They've taken the money and used it elsewhere, but then come in and ask us for new positions with
Right.
new monies when they actually have the positions, but they've cockroached the money and paid for something else or use it for raises.
Right. And because of the way we're structured, no, that's not the way our positions are funded. So it's a different
But it
type of.
seems that way, because if you have no money there and if we take away the position, because if you can't fill it, and you're not gonna fill it because you no more money there. You've taken the money, and also, are you going to put the money back in once you get rid of the contractor?
Because here it says budget amount, it's empty, right?
Yeah.
Yeah.
So where do you,
Can you
if
fill
that's
it?
filled, how are you gonna where are you getting that money from?
Yeah, sure.
So it really is, in some ways, a clinical operations question. So let's say you have a position right now that says RPN 3.
No, we can just talk about the real one here, Infotech Specialist 5.
Is that the
It's
one we're
ongoing
speaking
since
of?
2019, but there's no budgeted amount.
I thought you were speaking of a different. one.
Talking about it all.
Yeah, it
Same
doesn't
thing.
matter. It's just a vacancy that ongoing recruitment, some have money, some don't. Right? Like you're saying, you don't fund all your vacancies. Just in, I guess, whatever your strategy is. But in this, I think that's what everyone's trying to understand is how do you, we want to know what, when people don't fill, they move the monies around for the vacancies. We never know what they move the money around for.
Maybe this would help if I just gave it in the form of an example. So if you have 100 nurses that you need to operate, you may have at any given time 15% of those nurses you cannot fill, but you still have to provide the service. So you use contract labor. So often what we'll do when we go into a budget year and we budget, we will estimate of that money for those 100 nurses, 85 of them are in the salary benefit side and 15 of them are over in the registry contract labor side. And what will happen as we go through the year, that percentage may adjust and we'll move the money back and forth. So some of those positions, like the 15, they're there, but we know that we're going to use them as use the money
Yeah.
that in theory is there for them for contract labor, because it's always moving from those
Yeah, but
two
that's
buckets.
where the money is budgeted. In this case, there's no money budgeted. So how, if this is filled, where do you get the money for this one?
I think it's because you still need, in that example of the
Yeah, I
100 nurses,
think.
you need the
Not I
100,
think.
huh? What's that?
Not I think. Not we can't guess.
There
We
is
wanna
money
know what
for
the
those
real-
100 nurses. You know that you're going to spend money for nursing labor. It's just, it's in some mix of.
No, I get that.
Yeah.
I'm talking about a vacant position that has no money. How are you gonna fill it? And where does the money come from? If there's no budgeted amount.
Well,
Might as well just cut the position. There's no money to it.
yeah, so in the case of where, like, say, this info specialist 5, if there was a candidate that came up and was able to fill the position, we would try to find the savings for somewhere else to fill it versus just
Another
adding
position.
another person.
Take it from another position that.
Another position, or if we find some contractor savings somewhere else within the organization, we can try to fill it that way, at least for the short term.
So when you contract, don't you have a budget for contract labor?
Yes, we do.
So you have it, but yet you're still taking money from positions to put it for contracts? See, this is the problem we're having, because that salary monies was not intended to be for contracts. If you need for contracts, then you're supposed to have, like you said, you have money for contracts. Right?
Well, in general, in our case, when there is a, let's say the registry nurses are a good example. So, even though we may not have a salaried employee ready for the position, that function still needs to be done. We still need nurses at the bedside. The only way we can fill that position is by using contracted labor. So we're
They don't
utilizing
want to apply?
Huh?
Because they don't want to apply?
It's,
various
it's,
reasons.
it's in the variability. If we look at what we spend to deliver the nursing service, that's pretty consistent in that budgeted amount. Within that budgeted amount, though, there are two buckets: what we pay for salary and benefits and what we pay for contract labor. And we can't predict that cleanly ahead of time. So sometimes part of the year, you may have 30% of your money in that bucket spent for contract labor. And by the end of the year, when your new grads come out and you've employed them in whatever, you're all down to 10%. And so we have to have a bit of ability to move between those two budgeted amounts.
Okay,
so
let's
that-
talk about non-medical, like you have here, health unit clerk 2, that's been vacant and has no monies at all. You know, and you have other kinds of technical regional EPR director, no monies in life, vacant. So how do you justify those? Obviously, the work's being done by somebody currently in the position, in another position, you've obviously put more work, right? You've overlapped or whatever, so how do you justify those?
So I know what happens, as we get near a session, we generally do a position cleanup over the year of positions that you don't need and abolish, because we have the ability to create positions. So, for example, you create, you maybe there's 10 health unit clerk positions and you fill 7 or 8 of them, and you've changed some of your operations, and then you ask that manager, you still need those positions? Are you still actively recruiting for them? And sometimes they go, yeah, we're still actively recruiting, or go, no, I don't. Well, they go, well, then you need to abolish that. So we are constantly going through a posting as our operation change, abolishment of positions, because we have the ability to create, but we also abolish. Just before session, over the last couple of months, I probably cleaned up, the 20, 30 positions that for different reasons aren't being needed.
So
because
if you can create your own positions, why not just delete the ones that you don't need and just clean this up?
Because
And then when you need it, then recreate it. But what's the mechanism for creating it?
Because the managers often will go, well, I'm not too sure. I think I'm going to need that Tech 5 out there.
I know,
And
but
then,
some is like I said, since 2019.
well, that one we probably should have got rid of, bluntly. But in general, it is a cleanup function that we run into where managers understandably want to just in case hold on to positions. And then we have to tell them, if you're really not going to.
Well, how long does it take to create a position?
We go through what they call a HRO1 process.
Who
It probably
who
takes-
does it? You? What's the
Um,
mechanism?
yeah, so for the corporate office, it runs through our HR department. Generally for the regions, when they need to create a position, they initiate the process, and then it also runs
Who's
through
the
our
final say?
in our
the regions.
it's the
Oh,
regions.
each region.
We just make sure that they're in the proper classification
I
on
sign
the corporate side.
HRO1 for a position. I also sign every abolishment.
Okay, because
Can you send us a list of all the abolishments you've did for the last few years?
Absolutely.
So we can take a look.
There are
at
actually
it?
quite a few.
So you don't ask us for positions.
No.
No, we don't. Yeah, you notice our position count. If you look at the budget worksheets, the position count is very outdated. It hasn't been updated for many years. And the reason again is because the statute gives us position control to create and abolish positions.
Sure.
Senator Favela.
So by saying what you've been saying, I was listening, yeah? So you guys, are you guys in a process where you guys are using other employees from other departments to make up the staffing shortage? And if you guys are doing it, how is it qualified to ensure patient safety? Because what you're telling them, and maybe you're saying you're abolishing this, but it seems like you guys are, I don't like say sharing, unless you have a custodian doing nursing work, but you guys are moving people within the department to do other work that you guys are shortage on. So how you guys?
No, is that the case? Because it sounds earlier like if you don't have,
Oh,
if the position isn't filled, you contract it.
We have the
But
ability to do
Is
that.
it
Yeah.
contracted like what
Yeah.
he's saying from another
So are you
department?
guys doing that though? Are you guys using our employees from other departments to fill?
Well, well, go ahead. No, in the case of the like the registry nurses, those we use outside agencies. So a private agency has a nurse staffing agency. We go to that staffing agency to bring in the nurses for that position. We in terms of how we manage
Maybe it's really an outside company.
outside agency,
Because
outside
I think
company.
Your agency.
Yeah,
I mean, that's an agency. Yeah. It's an outside company, outside vendor. I
Maybe
would say.
that's where there's
Yeah, we don't have like, we don't use like clerks to fill nursing positions because they're not qualified. So,
Yeah.
like I mentioned earlier, that part of the HRO1 process or the establishment process is looking at the classifications. So that's what our corporate office does to make sure the classification for the employee is correct.
So
And then,
do you borrow or have a partnership, I guess, besides the cancer center with other agencies for staffing or no?
not other state agencies, no.
Okay.
So even like what you're saying, you guys having issues with CNAs and you use an outside whatever agency or business or whatever to fill the position. You guys, how you guys market you guys free CNA program?
So we don't use contract businesses to provide us CNAs. They don't exist on the neighbor island. However, we do operate and run training programs to train local kids to get them certified,
Yeah.
offer them jobs and get. them
Yeah,
work.
that's not, remember when we went to Kona?
Yeah.
They started their own program because I'm not sure if the UH wasn't.
Well, the reason why I bring this up is because you guys saying you guys don't have these certain positions, but you guys creating or doing your guys own, but you guys only have a small amount that you guys are producing within you guys self, you guys are outsourcing more than you guys are actually bringing in?
Actually, for CNAs, again, we don't use any contracted labor. The only contract labor we don't normally use are for nurses and then also for imaging techs and the ocular therapists. And we only generally do them between the transition period when, for example, if I have an ER nurse and the ER nurse says, I'm gonna give
You
you
gotta
2
make
weeks
sure you
notice,"
see
great. If
table.
you're on the neighbor island and that ER nurse, I need to replace them, pretty much all the ER nurses are either working in our ER, West Hawaii, or North Hawaii. So we then, though, it takes us about 4 to 6 months to recruit a new ER nurse, either from the mainland or train someone to be one. So in the interim, you still have to staff that ER. We use contract labor to cover that piece. And that's pretty much a consistent percentage of our workforce is somewhere between 10 to 15% are in that transition stage, and that's not going to change if we're going to maintain levels of service.
So even like you guys telework or you guys work from home, you guys have a lot that going on. The one that I'm concerned about is that I seen that you guys have a pharmacist that is working remotely. How does a pharmacist work remotely?
We don't have any East Hawaii that works remotely.
Yeah.
There are some functions where, folks will take call,
And that way it's
but I think remotely, I don't believe we have remote funds.
can ask how much of what.
I think that position may be someone that maybe actually was working as in our EMR as an analyst,
Yeah,
but they are technically classified as a pharmacist, because they work on the pharmacy module, the EMR.
right?
So that's why it's classified as a pharmacist, but they're doing telework.
Doing telework.
You don't have to send me the abolishment thing. I see on here some of the positions that you have here that says.
There are some that are listed as abolished, yes.
Chair, Chair, can I talk to, table 15 CIP request, short, renew, information, Kona Hospital. What's the relationship with, Queens Hospital? Because we did have the release from Queens, but I noticed that the $1.3 million for this year, is that for plan and designs and location seeking? Because you're going to need more money if you're going to relocate where it's going to be, and plan and designs. To me, I think 1.3 is not going to make it, but
was that
I was just questioning.
But that was, yeah, this
That's
is
just for the emergency room.
Just for the emergency room?
Yes.
Okay, so not part of the new Kona Hospital then?
That's,
No.
Okay.
No,
so
that's
Kona
preliminary too. I'm not sure
That's-
that's real yet, huh?
So Kona Hospital, any funding for Kona Hospital for the new hospital is not in this budget?
Correct.
Okay,
No.
This is just for our current operations as is.
thank you very
And
much.
that wouldn't be in our budget
That's right.
because it's not our hospital.
That's why I'm going to say, where is Queens involved with it? But now it's clarifying that these are only
No, but
sort of R and
That
M.
announcement was
Yes.
premature. I don't think it's finalized yet. So it's not it's not determined if Queens is actually going there or not.
And you know what, though, that announcement got people excited because they're all thinking
That's
they're
why I
gonna
said it
get
was
a new hospital, and
premature.
that's why I'm raising it. But thank you for the
Oh, So in the
clarification.
meantime, they gotta support this 1.3.
Exactly, exactly.
Yes, they need the help,
It's well
definitely.
needed.
Yes, they definitely need the help to
Okay,
redesign that
I know
emergency
that
room.
the health chair has a
just
couple
one more
questions.
shot. Can you come back up? Sorry. Okay, one more. You know, the 5.6 million and 5.1 million on your table 15. Any of those monies to upgrade Leahi so you guys can get more Department of Health
Unfortunately,
patients?
no, Chair, this is funding for just some deferred maintenance projects for just bringing the facility back. As you know, both Leahi and Malihi are very old. These funds are simply to maintain and bring them up to normal standards. But I will say that I know that Chair De La Cruz is very informed on this. We do have a project in place with the University of Hawaii School of Architecture, the community design program. We just contracted with them. We have the funds already committed, and we're doing a kickoff with this team beginning next week. And what it is they're doing a full assessment of these spaces that you're referring to on the Leahi campus
Yes.
to give us a really clear idea of how we're gonna bring all of these dilapidated spaces up to form where they can be repurposed for these new programs. So
And none of those monies are here. I mean,
it's already funded.
it's already funded.
Yes.
Okay, thank you.
I guess, I want to go to table 13 real quick. I noticed, Hale, oh, that was your question. Oh, well, why don't you ask it? No, go ahead. Go ahead. What, the 15%, is that just anomaly or?
Yeah.
I can do.
Because everything's about 4 to 7.
Yeah, I mean, the Hilo Medical Center is, and Leahi is probably the two higher ones, but this one was kind of high.
So the question is, why is it as high as 15%?
Yeah.
Have you been to Honokaa? You've been to Honokaa. So Honokaa is a very, I would call it a very tight, isolated community. The Honokaa Hospital is actually the largest employer, and they've always struggled to get mostly nurses and LPNs to cover and staff their staff all the way to full. And the reason being is most of the nurses either want to work in Hilo or they want to work in Waimea. So what we end up doing is doing a lot of overtime to meet those staffing levels. We even have, for that facility, the CNAs that work there, we've had to put in a $5 an hour facility differential to pay them $5 more an hour than someone who works in Hilo, because you just can't get that staff. And so what ends up happening is people do a lot of overtime just to meet the safe staffing standards.
The
Now-
commuting.
Absolutely. And
No, they can't get
like
any
what-
nurses in that area.
What's that?
You're saying you can't get nurses in that area.
I can't get nurses, and surprisingly even aides. I think a housing is a piece of it, because in Honokaa, you have a limited amount of housing. We've run 3 CNA courses to try to address that overtime issue, where we actually guarantee people employment. While they train, they get paid that going rate through their training, they get their CNA and they have a job. And honestly, we've still only been barely able to keep up. So it's just a realistic number. I mean, I'm
Yeah,
glad.
so how
honestly,
much-
the people will do
If
the
that's
work.
an issue on some of your properties, you don't have room for housing then for employees?
On the Honokaa property, it's very much, you actually could expand some housing there. It's potential. We have a few cottages. Some folks use them, but mostly the people who are transitory, the staff themselves lives in Honokaa. But, you make a CNA's wage, it's not huge, right? And so housing is definitely a barrier. So a lot of the younger people that we need to come into the facility as the folks retire, they're going, they're not staying. So it's a challenge, especially in that kind of isolated community.
Until DHHL completes their plans, because they are planning right above the hospital, that vacant lands to build. We got the reports yesterday that they're building housing over there. That's one of their criteria.
Well, they don't
So
know
hopefully-
yet.
But,
They're saying that's on
it's
their
a-
wish list.
yeah.
They
But
can't say it was
people that-
finalized yet.
Somebody will come and develop some housing.
There's gonna be
soon.
more of that.
And then
where
table
it's-
14. I noticed with HTH 215, the contract expired in 2024, and there's still some outstanding balances. The 356,000. Is that normal that the contract expires, but the balance is still?
That was HH 215?
Yeah.
215?
Which I
So I'll read your contract.
think there's a lot.
Sorry.
Three.
I was informed that was the error and it'll be correct.
Oh,
That shouldn't
okay.
exist.
Okay. And then let's see, table 22. No. What is C? What does that mean? C note 1. Where you have
Which
reason
table?
for telework.
Are you
Right there, reason for telework, the last column. That says C note 1,
on table 14 still?
no, 22.
22.
Table 22.
So you guys have,
Yeah, there's a
oh, so
note
the
on,
contract manager, they telework 5 days a week.
yeah, they work up regular,
Oh, okay.
regular work week. Yeah, there's a note on the.
So all the guys that telework are, I guess that they're not medical staff, looks like, yeah. Looks in,
No, most of them are like the back office type function. So you're talking about IT people, you're mostly like accountants, billing clerks, those kind of positions.
the VP and chief info officer.
Yeah,
Two to
that's our
4
director of information technology at the corporate level.
For that amount, you would think they would telework less.
They would telework less.
Yeah, with the, look at the salary.
Yeah, well, with the IT person, the access to technology is easier for them than for other
Oh,
employees.
it's that kind of info. I thought you meant like communication specialists. Like the person who, because you would have to be there if things are going on.
No, but there's other staff on the
Oh,
ground
yeah.
that take care of those, the technical issues per
No,
se.
yeah.
And if there are issues that
I
arise,
thought it was, I didn't think it was information technology.
yeah, that's our vice president of information technologies. Yes.
So what is C note 1?
There's a note, I think, I don't know if it printed out on yours, but there is a note about the how it refers to our policy during COVID for telework.
Well,
I think
maybe the
that's,
staffs can kind of.
yeah,
follow up.
I can send them the
Yeah,
note.
okay. And then I notice, how are some of the registered professional nurse hybrid? There's some in there.
Same table?
Yeah. If not, you guys can just, I'll just put it in writing and you guys can respond.
Okay, that's fine.
Okay. Okay, we're gonna take a recess. We need 10 minutes and then we'll have Department of Health come in.
Oh, I'm sorry, Chair. We also have Tohoku Medical
Oh,
Center
that's right.
and Maui Health System that would like to testify as well.
Oh, okay. Kahuku was my old district, so I better let them talk.
Aloha, Chair, Chairs, Vice Chair, Senators. Thank you for giving me this opportunity to speak in front of you folks. Excuse me. My name is Matt Mamizuka. I'm the Chief Operating Officer of Kahuku Medical Center. CEO Steve Nawahine, he sends his aloha and his regrets. He's in the mainland for his son's wedding. So he appointed me today.
But you guys only have one request, yeah? Is that only one? The 125,000?
Request.
No,
I thought you said the first one was Kahuku on table 6. No? Was I mistaken? Is that somebody else's?
$2 million.
But it's over to recommend. No.
Okay, we can take a recess. And you guys, you need a minute?
yeah, I think we're good.
Oh, okay.
So, yeah, so we're going to be requesting for the full funding for operations and CIP, that 125,000 that the governor provided.
Yeah.
So that's for the transportation vehicles.
Yeah.
Being so rural, we find that very important. A
Yeah.
lot of our kupuna are unable to make it to our
And that's a
facility.
that's a one-time expense only.
Yes, that is.
Okay, and then what was the CIP one?
So a little background, and I'll be quick so we can take a recess. So we span our families that we serve, range from Ka'awa all the way to Wailua. With your folks' CIP funding in the past, we have been able to increase services, dental services. We started a brand new behavioral health program. We increased our clinic capacity from 4 exam rooms to 10 exam rooms, and that's all thanks to your folks' CIP funding. So we really appreciate it. A lot of our CIP requests for 26-27 is mostly infrastructure. So we are an aged facility and no different than the other HHSC facilities. We share the same concerns
Okay,
and the
so
same
5.8
challenges.
the first year and 5 million the second.
That's correct. And we appreciate what the governor recommended. And we stand by that 5.8 and $5 million, and it's going to great causes, great projects. As far as operations, we requested about $4 million for 26 and 27. Governor recommended about $2 million. And we humbly request that we get fully funded.
Wait, I don't see that. That's in
for
table 6 too?
operations.
No, that's not in table 6. So what he's going over is what he actually requested to the governor,
Oh,
but the governor did not necessarily make the
oh,
recommendation.
okay. You might want to have your current legislators at least introduce a bill for the things that didn't make it in.
I see. I'll go ahead and do that.
Only one question. You guys, dialysis, you guys have that, is it up and running already?
So we do not have a dialysis program up and running yet. We have been reached out to different companies. So right now, so all of the decisions, of course, is data driven.
Yeah.
It's very, very expensive to run a program. So there's a couple of different options that we have. We have home dialysis option, or we have in-house facility option. But again, the capital cost to start a program is very, very expensive. You're talking between $7 and $10 million. We do have the patient population to start a program. It's just the initial capital. And so I always say our motto is friends and family taking care of friends and family. So the way we're looking at things is instead of needing a dialysis program, what our goal is to educate our community from Keiki to Kupuna about different habits. So 2 generations down the line, we won't have a need for a dialysis program. So that's how we look at that. But as far as our needs for today, we could definitely use them, but funding is always the
closest facilities were like Lehilia and.
Correct. So there's one in Kahalu and one up in Wahiawa. So Kupuna have to drive. I mean, they take their whole day. They're spending their whole day driving to different facilities, and it's taxing. It's very taxing.
I know that was a concern. Thank you.
Yes, thank you.
Okay, we're gonna take 10 minutes so that we can have Department of Health set up.
Thank you.
Oh, you had a question?
Oh, you have a question?
Oh, yeah, that's right. That's right. The finance chair must be thinking, oh man, he's sending me a message.
Thanks, Lynn. Aloha, I'm Lynn Fulton, the CEO at Maui Health. Appreciate the time. And I can be quick with this. I celebrated 1 year at Maui Health earlier this month. And so I've spent a lot of time the last 12 months getting a good handle on where we are financially as well as how we are operationally. If you remember last year, we had presented a plan that we have to get to zero subsidy, and we are following right along with that plan successfully. Last year, we had requested 7.5 million. This year, you'll see in the governor's budget, we have decreased that to 12 million. And then our plan for next year will be 6 million and then zero. So I respectfully submit that, but happy to answer any questions.
Any questions? Thank you. Okay, recess. To reconvening the joint committee. So now we'll hear from Department of Health, who will present their biennial budget requests. Yes, good afternoon, Happy New Year.
Chair.
Aloha.
Chair De La Cruz, Vice Chair Moriwaki, WAM committee members, Chair San Buenaventura and Vice Chair Aquino. I'm Kenny Fink with the Department of Health. With me at the table are deputies Marion Suji, Kathy Ho, Valcato, and Debbie Morikawa. And we're also accompanied by other subject matter experts from the Department of Health if there's other questions that we need to ask some help with. Okay, so thanks for meeting with us today. And I will jump in I made these slides before knowing the 15-minute time constraint. So either I have a couple more minutes or I'll go real fast. We can visit back. Okay. Department of Health, our mission is to protect and promote the physical, behavioral, and environmental health of the people of Hawaii. And we do this following the CDC's 10 public health services essentials through assessment, positive development, assurance. Our vision is that all Hawaii residents have a fair and just opportunity to achieve their optimal health and well-being. That is our why. And this is our how. This is kind of a new strategic framework. We have our values on the left-hand column there. And within that framework, the foundation is to optimize operations. And those are sort of the key things that we've been working on: administrative efficiency, leverage technology, and increase filled positions. And then those three areas that can be within programs of really the concepts of trust, trust with the public, capability, both our capability to produce information the public can understand and the public's capability to understand it, and ensuring that what we're doing is effective. We need to make sure what we're doing works. And at the top level are really the cross-departmental areas for the next couple of years, and they're interrelated. So we've been incubating those with your support and resources within various divisions. And my vision is essentially would have like an office of offices with those cross-departmental functions that are interrelated. This is just an org chart. We have over 70 boxes, and all of the programs really are going to be responsible for the what. So if they understand the why and the how, my expectation is that they, as the subject matter experts of their areas, will develop the what and make recommendations on the what. The who. So I just want to pause for a moment and express my gratitude for the work of all of the DOH staff. I'm grateful for all that they do. With a 30% vacancy rate, everybody is doing a lot. And I want to recognize that and appreciate that. So for our civil service rate, it's 28%, but overall, we have a 30% vacancy rate. When I dug a little deeper to see what's vacant, there's a pattern of lower level positions have a higher vacancy rate. And if that's our pipeline, then that is a concern that we need to make sure we're getting folks in at the lower levels so we can, again, develop them and have them move into the higher levels. So this is one red flag. And then the next couple of slides are going to be the data OWR survey. So this next series of slides, I'm going to compare DOH's results with all the executive branch's results. So I was quite concerned to see that for DOH, 43% of our respondents said that they are very or somewhat likely to look for another job in the next 12 months, compared to 36%. So I looked at this and what am I doing wrong is a question I need to ask myself.
There's a lot of people here that's willing to answer that.
Thank you. Thank you. I don't think there's enough time. Not enough time. So when I looked at this, I said, well, but actually compared to all departments, our staff are more likely to feel their work serves a greater purpose, to find their work meaningful, to feel their job is secure, and to feel they have more freedom to decide how to do their work. Where it's worse is they are more likely to say they don't have enough time to get everything done. Okay, what about just the work environment? Well, actually, while it's, I think, unfortunately low across the state, our staff are more likely to feel supported by their coworkers and supervisors. So I don't know that that would explain the why they're looking. Greatest source of stress is work. They just have a lot of work. And I think when they feel meaning and purpose, they care a lot about what they do. And the challenge is when they feel they can't do what they think is needed to serve their community. And that's taking a toll on their mental health. So compared to all departments, our folks were more likely to have poor mental health, okay, worse mental health days in the past 14 days. So that is a concern. And when asked what the potential solutions are, by far, more staffing and resources. Okay. So I want to say that these folks actually reported a higher satisfaction with life, yet worse mental health, which is interesting. One theory that was suggested by staff is that because they care about their work and can't do the excellent job they want to do, that is impacting their mental health at work, but the meaning and purpose is why they're satisfied with their work. So again, I truly appreciate all that everyone has done. We've had COVID, Red Hill, Maui wildfires, we're facing bird flu, and this is all on top of everything they're supposed to do with a 30% vacancy rate. So my gratitude to them. Okay, so what are we trying to do? So I need to try something. So we implemented a pilot. This is our hire pilot. And we did it from August to December 2024. And we did it with their unique classifications to DOH, for which we had delegation. We used those. And all we did was not verify minimum qualifications upon application for all applicants. We took all applications, we sent them to the program, and when they selected their one, we verified minimum qualifications before extending an offer. That was all that we did differently. So we had our 23 recruitments. That was kind of our sample size. 9 are still open. Through 3 of them, now we're selected. 3 were selected, and then they went all the way up and found that they weren't qualified. So people said, well, didn't you waste all that time? Well, if someone's not qualified, they could just extend it to the second choice. And for these particular cases, in one case, there was only 1 applicant, weren't qualified. That was it. Another case, they weren't qualified at the 4 level, so they're just going to repost it at the 3 level. And the third case was someone who's an 89-day hire who is just short of the required experience. So we expect, again, that will help. But what we really found was we shortened the period. When people apply for a job, they need the job when they apply. So from closure of the recruitment to getting applications, sending to the program doing the interviews, then vetting the minimum qualification for the selectee, to extending an offer, 60 days. We were able to do that. And you can see the times there. So we could do it sooner, and we'll get faster with more experience. And the efficiency was the avoidance of 56 minimum qualification verifications that were avoided. So the recruitment staff could again do other work instead. So this was a success. It was small, but we hope to see how we can learn from this and expand it. Okay, this is our top line budget ask. You guys have this in your books. For current fiscal year, we're 1.2 billion. For 26, goes up about 9% across the board to the 1.33 billion. And mostly we're focused on the A funds that go up about $40 million or 13% in the first year. From an FTE perspective, we do a lot of conversions from temporary to permanent. The total net increase is about 32 or just a 1% increase in FTEs. And then it's pretty static from 26 to 27. So just high level. As we go through our budget priorities, these are themes in our ask. We started with those that are just necessary to maintain current obligations and level of service. Facing this new federal administration, understanding what our federal funding might be at risk. And then we went to, as I mentioned, we're not going to have the workforce we want to have. So we have to, they're already doing more with less. We also have to do less with less. We have to find what can we stop doing. Mental health, substance abuse, environmental monitoring, and I'll talk about infectious diseases. So I'll go through those in a little more detail. So necessary to continue services. We have to maintain the Hawaii State Hospital. And while we're looking to place patients in the most appropriate setting, we have to keep it open and serve the patients we have. So there's funding asked in there for our locum tenens providers and also for overtime. Again, emergency medical services. We have to resource the collective bargaining agreements. There's a second ambulance that was appropriated for Molokai. The funding wasn't recurring, so we need to continue to fund that second ambulance at Molokai. We did a rate study. This is now the rate adjustment for people who provide services to individuals with intellectual and developmental disabilities. There are certain key positions that we can go into more detail that are either on the books but don't have recurring funding, such as a Kalapapa, because we just don't know the timeline. So those are temporary positions. So funding for those positions. The EMS medical director, we just need to expand the point FTE for that. It's 0.33, and we just need to, we're going to make it like a 0.75. And then the clinical laboratory director is a critical one to keep the lab open. To continue the lab in anticipation of what may occur, we need to separate out kind of the administrative operation and the clinical expertise to ensure we have that ability to provide everything that the state does. And then our long-term care programs, we need additional funding to be able to continue to license them. So those are some of our necessary to continue services. From a federal funding perspective, of all awards, which are multiple years that are current, the total dollar amount of all of our federal awards, we're somewhere in the award period, is just under $1.5 billion. We have encumbered over $1 billion of it, and it's at $436 million that is potentially at risk over the multiple years remaining in the contract periods or the grant periods. So these are just the examples of the grants that are over $1 million. The one that's missing is the tuberculosis grant was just renewed, and we did get the first year's funding. That's about $1 million annually. So this is just a qualitative, the average award amount per year of the award. So you can get a feel for how much money, if these were not funded, might be at risk. So we're just doing this exercise to understand our exposure. Okay, and you can look at that in more detail. So of that federal funding, it's about 12% of our budget and 438 positions. We are aware of some positions that have been communicated about positions on immigrants and immunizations. So we're concerned about those programs in particular. So we did ask for conversion of our immunization staff to ensure that we're able to continue that work, and also a tuberculosis X-ray technician. We want to ensure we're able to continue those critical services. The WIC positions, there are 16. These are entirely federally funded. These are particularly at risk if there's a government shutdown. If these positions are funded and from the state and the government continues to fund them, that money can be redirected into benefits. So those are the positions we've identified as being most critical in the event of a loss of federal funding. Okay, moving on. There's a big effort to basically improve our data and analytics processes and modernize all of that. We're investing in cybersecurity and data standards, the data warehouse, and trying to have more information to inform our decision making, as well as inform the public and stakeholders, including yourselves. These are a couple of key projects that are in flight. The electronic disease surveillance, immunization information system, and case management system. These are 100% federally funded right now. But again, the concern would be if that funding goes away mid-flight, we may be asking for funding to continue those projects. Okay, efficiency improvement, some things that we have done. I've used the term, it's death by 1,000 cuts, and I say it's, a healing by 1,000 Band-Aids. Every little bit, if we can remove one paper, one thing that has to be routed, it will add up. So all of these little things that we're trying to do will add up. So by themselves, they may not seem like much, but eliminating the notarization page, that was one more thing to chase. Going to electronic signatures, so paper doesn't have to get routed. Not requiring an E205 when it's not required by ETS. Pushing decision making down. So for inter-island travel approvals, the branch chiefs can do that. I don't need to, it doesn't need to come up to me. Simplifying the reorganization packages, and we're creating an HR portal. So these are just some of the things that we're really trying to look at and see what can we streamline internally. Kino holiday, we are grateful to the legislature for appropriating funds to pursue an opportunity. Truly grateful as we have exhausted that process and found limitations to the deed restriction. We understand that there remains an opportunity for the state. We support DLNR's pursuit of that. We are working with DAGs to locate alternative space and then also on a redevelopment plan. Okay, so someone asking the budget regarding to efficiency improvement. And the numbers you see in parentheses are the department priority. I'm sorry, I didn't clarify that. So these, you can see a vital record system replacement. Staff have worked really hard to improve the processes and the timeliness of turning around vital records, but they're just limitations to the system. It has a lot of manual processing. So we feel that it'll be far more efficient to invest in a new vital record system. Cronus integration with HIP. HIP works fine if you're not a 24/7 operation. We learned from HHSC that they have actually created this first. So we're trying to look to expand that to our state hospital. That will help with scheduling, time creeping, reducing overpayments. A lot of benefit to that. Grants and contracts fiscal management module. We're coordinating with DAGs and understanding that they are looking for a new kind of fiscal management system. This is a module that would work with that. And we're in communication with other departments, including DLNR and maybe DHS, to see if multiple departments could share this that have a high volume of grants and contracts to manage. Early intervention data system, that's another one. And then also as a force multiplier are really investing in our human resources. If we can get more positions, we can increase our recruitment efforts. So all of these things become force multipliers and helping offset some of our vacancies. Moving on to behavioral health. So on Maui, again, we're very active supporting the survivors of and those impacted by the Maui wildfires. SAMHSA was a huge partner in support. So services that have been available over this past year, you can see the talk story, case management, traditional healing practices. Oh, sorry for the typo. And then that gives you a feel of the services that were delivered. So these are contracted services to try and use local organizations as much as possible. And they have done an extensive amount of servicing trying to meet the needs. We started the Behavioral Crisis Center in Iwilei in this past year. The chart on the left, I think what I'd like you to see, and this is only complete through November when I pull this, you can see the columns are increasing. So each month, there's a trend for increased utilization of people coming and being serviced at the Iwilei Resource Center. And we just saw the December data this morning, but I couldn't update the slide, and it's even higher. So continue to see increased utilization of the Iwilei Resource Center. On the right is a disposition. And what I want you to take away from that is that 60% of the people who are seen there are connected with services, which is actually what we would consider very successful. So they're plugged into services. A lot of it becomes some residential-based or housing-based services. So I'm pleased to say that these data would indicate that the center is doing what we hoped it would do. Okay, moving to the state hospital. On the left is the census by month. That horizontal line is what it is licensed at. So it is licensed at 292. And you can see since it starts with January 2023, we have significantly exceeded that. We've had to get waivers to do that and be in compliance. As we got into the late summer, it approached nearly 400. So that's a 30% increase. Some of what has been included in there was a closure of Kahi, Mahala, and those 48 beds. So those effectively need to get absorbed in the state hospital. So that was the census. Below that shows you the kinds of patients we're seeing and high volume and basically churn of the petty misdemeanor patients. To the right, we've really dug in and tried to understand who's there and why are they there so we can develop the appropriate responses and interventions. So in doing that analysis, what they found was there only about 13% truly need that level of security and intensity that the state hospital can provide, 13%. 7% are there waiting discharge, and that is finding appropriate placement in the community. And then about 80% have some outstanding forensic issue, which is prolonging hospitalization. So this helps inform us for where we need to go next in developing appropriate interventions. Okay, so our request for behavioral health. We are doing an ongoing rate study, and we expect in the supplemental will come in for an additional ask for a provider rate increase. Again, we appreciate the appropriation of 10 psychologist positions, and we're requesting to fully fund them and make that recurring funding. Another ask is that alternative care site. So for the low-level folks who may not need that level of care, looking to find an alternative, lower cost level of care. Moving from the state hospital to just the community needs. We focus on those with a serious mental illness, but there's a broad population that needs mental health needs and has difficulty accessing mental health services, including for things such as depression and anxiety. So the certified community behavioral health centers are a model for all comers to just be a resource to service anybody in the community. So we're asking for resources to advance that concept. We have a pilot on Maui, and we're looking to build that out and expand that to the other neighbor islands. Not in the budget, but we have a bill for an intensive mobile outreach project. So this is for really the most severe folks who are primarily homeless, to see if really with an intensive intervention, we can get either better stabilization or potentially pursue ACT. But we know that there's concern about the homeless issue, particularly on Oahu. So whereas the CCBHC focus would be primarily on neighbor islands, this pilot we would start with on Oahu as proposed. And then for the state hospital, sort of that other bill, when patients at the state hospital need to get medical care, we need to get either a procurement exemption, right? Get a contract, negotiate a fee schedule, and then basically process an invoice. And we were in arrears as much as 2 years. So we've cleaned up that backlog, but we're looking to streamline that process by getting a procurement exemption if state hospitals need to go to a medical hospital for care. And also if we can align it with the Medicaid fee schedule, and if these patients weren't in the state hospital, they'd likely be Medicaid beneficiaries, then we can partner with MedQuest to do the claims processing, be way more efficient. Okay, so those are just a couple related bills. Moving on to environmental health. The image here right, the red dots are where new monitoring wells have been created. So we continue to be very active overseeing Red Hill. And with these new monitoring wells, there's ongoing groundwater testing. Staff are reviewing the closure plan for Red Hill. The tank cleaning plan, air monitoring plan, and tank cleaning verification plan have all been approved on those dates. We provided comments on the pipeline removal plan. The site assessment investigation remediation plan was disapproved, and that needs further work. So again, we're still continue to expend a lot of resources working on Red Hill. PFAS. Basically beginning December 31st, that HRS 321-602 became effective for packaging. So we did communications about that. The EPA had issued a rule, and there will be new maximum contaminant levels for 6 PFAS that will require public water systems to begin monitoring, informing the public of the results, and complying with those levels in 2029. So there's still a number of years out, but there's a lot more to come about PFAS and planning for that. The graphic to your right are all the locations where PFAS has been detected. So it is widespread. Testing is not required, so it is likely more prevalent. It's just these are just the places where they have tested and have found it. Staff did a study on PFAS that's available on our website, finding that there were low levels in wastewater, which was reassuring, and much lower than compared to some areas on the mainland. As expected, there are high levels in landfill leachate, but if that gets properly treated, it remains controlled. And then they also sampled AFFF release sites, known sites, and of course, those are high levels as expected. So we can refer folks to that report. Cesspools. All cesspools shall be upgraded or converted by 2050 per that law. The legislature appropriated $5 million last year for cesspool conversion grants. We awarded 243 grants for $4.8 million. Of the nearly 14,000 Priority 1 cesspools that were identified in the report in 2022, the grants converted 243 of them. Slightly less than half of the conversions, I think there are about 530 or 540 total conversions, about half were funded by those grants. So the grants are really helpful in getting the conversions to occur. For the individual wastewater system applications, this is our backlog. We recognize that there are other permits that are awaiting review by us, building permits. And we'll talk about that. But these are just the cesspool conversion permits. Okay, so environmental health is requesting a couple positions for pre-treatment wastewater testing. This is regarding the underground injection well decision that's required to be regulated. So testing for that. There's an ask for $5 million additionally for other grants for cesspool conversions and staff to manage that. There's been a lot of interest in nearshore water testing, again, particularly in the neighbor islands. So these positions to help with that. And again, we hear the landfill issues coming up. We need to continue to work on sustainable solid waste management. So position for that. Okay. All right. Shifting gears. Public health success is typically the absence of something. What have we prevented? Which is difficult. Whereas a lot of the things you're looking at how effective, how much did you accomplish? How many of these things did you do? For public health, it's how much did we avoid? Every condition up there was something that was reported to the Department of Health that we investigated. So these are all the things that hopefully you haven't heard of because we were doing our job. Okay, so lots of things. Okay, vaccinations. Vaccinations are very important for preventing some of those infectious diseases you saw on the previous slide. On the left is just, you can look at the trend over the past about 5 years. And it is a downward trend over overall vaccination rate. That horizontal line is at 95%. And we're looking at measles. 95% is considered herd immunity. We are below 95% and seem to be staying there. And there's concern with statements made by the Secretary of the Department of Health and Human Services nominee that there's concern that this trend will go further down. And we are at risk for a measles outbreak. Okay? And the concern is that this trend will go downward. On the right is the trend in exemptions. The bottom line is medical exemptions, and then the top lines are non-medical exemptions. And you can see the trend in non-medical exemptions, right, is kind of reflecting or the mirror of the vaccination rate decline. Avian influenza, it's getting a lot of our attention now. There's collaboration among state and federal partners and counties. There have been no confirmed human cases in Hawaii. There have been 66 confirmed cases as of the date of the slide on the mainland. Largely those who are in industry, working on farms, poultry farms, dairy cow farms. There's one case of a backyard flock exposure and 2 that are unknown. The cases have typically been mild, but there's concern about that patient in Louisiana who just passed. Patient was older, had comorbidities, but still, the virus appears to have mutated within the individual. And it's raising a lot of attention. Of all these cases, there's been no detected human-to-human transmission. The CDC still, at this time, considers the risk to the public low, but everybody's very carefully monitoring this. So in Hawaii, to the top right there is wastewater testing. And our state lab has done a terrific job, and they were the first ones to detect the H5 in the Wahiawa wastewater. Subsequent testing, it's been negative. They also detected it in Gila wastewater, and that has continued to be positive. So they're looking into that. The bottom is just a graphic to show, that the bump in the middle are COVID cases. That just shows a decline in COVID. And then the bottom line that comes up steep on the right, influenza cases. So avian flu is in the family of influenza A. It just right now doesn't really infect humans, but there is influenza A that does infect humans. So we have to, once we find it's positive for influenza A, you have to do further testing to see if it's this H5N1 specifically. So we work with the clinical labs and they send us their positive results so we can do further testing for surveillance to see if any of those influenza A cases were in fact bird flu. So that's a monitoring that we're doing. Other monitoring that we're doing, We continue that wastewater. And I think today we started our raw milk sampling for that one dairy on the Big Island. So these are some of the surveillance activities to see we can find. Some of our requests specific to kind of emerging infectious threats with climate change and anticipating where threats might be over the next couple of years, asking for a vector control outreach, a public health veterinarian, and this public health program manager, largely to allow our state epidemiologists to focus on really their role as state epidemiology and not just administering a division. We have two bills regarding this. One is for a vaccine purchasing program. The state can purchase vaccines at a less expensive unit cost. It can be self-sustaining if the state could then bill the insurers for that, but it reduces providers having either to front that money and pay for storage. There's a lot of benefit to providers to help it make it less expensive and easier to administer vaccines. Looking at the exemption rates, we also are proposing a bill to look at non-medical exemptions for the school entry requirements. Okay, CIP request, you have these. Really the themes here, the state hospital has a few ask, Kalapapa, a few recurring ask, and then our revolving funds, which again are kind of annual ask. Some operational challenges, larger result of our vacancies, morale. It's tough. Folks are tired. They're working hard. You can look at this, but, we're treading water and we're getting by, taking a lot of effort to do that. But the real limitation is to just have that heads up time and say, what can we do better or differently or more of? And that's the capacity that's really challenging us right now. So again, I do want to reassure you and the public that we are able to do what we're being asked and expected to do. But as we're looking that we need to work differently and better and innovatively, that's the challenge, right? That's the opportunity that the vacancy shortage, I think, mostly impacts. When we look at our staff and their well-being, it impacts them too. And it's just not sustainable to expect them to keep up this pace. So, I was speaking to a couple of folks and I said, what are my priorities? I really am concerned about the declining vaccination rate. There have been measles outbreaks on the mainland, and I'm really concerned that we are at risk of having one here. And then my second concern is really the staff and what they're experiencing now, and looking at the pipeline, the 43% looking for another job in the next year. I have a sense of urgency to address this so we can continue to fulfill our mission in protecting and promoting the health of the public. For communications, information is an incredibly important part of what we do in public health. We've issued 158 releases over the calendar year. We've restarted Community Bulletin, and we're trying to expand our social media presence. If you are not following us, we encourage all of you to please follow us on social media. And we're available for your questions.
So did you cover everything in table 6, or are there other things in table 6 that you have to highlight?
I believe there are other things in table 6.
You want to go over those that are not mentioned?
Okay. Let's see, I'll go through an order here.
You can skip the ones you already.
Will do.
And if you want to group them by program ID so you can summarize, that's fine too.
Okay. Well, let's see, we'll do this. I'll do this. I'll take it. Okay. All right, so looking at program ID HH100. I think for, so party-wide Hansen's disease. Oh, you're gonna do this one. Looks like with the Hansen's disease.
Okay, so is that working? So for the first one, it's our 6 Kalapapa positions. And again, while they were issued to us, the funds were appropriated in 22 and 23, they still needed to be established. So it's taken us, and they were only given, I guess, temporary funding. So we do need those 6 positions. We do have 1 filled. We have a janitor in recruitment, and the other 4 need to be established. For our community Hansen's disease program. A lot of people forget that Hansen's disease still exists in our community, and we do track and monitor and provide treatment for it. And so the funding from the feds has been level for many, many, many years. And we have not been able to fill a number of positions as a result of that. So we are asking for an RN4 and an OA3 to be able to make sure that we are providing that tracking and treatment for the community-based Hansen's disease patients. For our TB program, we are looking for converting a federally funded position to general funds for an X-ray tech. Again, the X-ray techs were taken away from us, and so we've had to recreate the positions again, and that takes time. But we do have a trade-off for that. We're training our epidemiologist specialist 3 and converting it from temp to perm, and then redescribing it to be an X-ray tech. And again, this is really critical because we do know that Hawaii has one of the higher rates of TB because of the immigrants that we get from the Philippines. And so one of the things that we need to be able to do, and in the schools as well, is screen for tuberculosis. TB X-rays for TB screening is one of the quicker ways to determine whether or not somebody has potentially a case of TB. For the public health nursing program, we have been experiencing a shortfall over the years. It's one of the most critical programs to make sure that we can address people in the community that can't get to, let's say, a clinic or a healthcare facility. And one of the things that we're facing is that we're not able to pay our utility bills. So if we aren't able to get additional funding to pay for our utility bills, we may have to shut down some sites. So again, we're asking for $350,000 to cover the shortfall that we've been covering with other sources of funding, but it's been very challenging. For the public health nursing program, also right now we have an admin specialist 4 that we have been funding with. We have grant funding until 5/26, and so we are asking for additional funding to be able to continue funding this position beyond the grant funds. And the next one.
The question, Chair, that 350,000 that you're short for electrical, is that an ongoing cost, or is that you just getting up to whatever you have budgeted?
It would be a recurring
250 a year?
Yes.
For electrical?
Well, I believe 177,000 is for the utilities, and then there are other things like vehicles, so their vehicle expenses because they are traveling. But we've been kind of band-aiding it by pulling funds from other sources, and it's just becoming more and more challenging.
Can you follow up, just to follow up, can you tell us where your shortage for utilities are located? Or is it buildings or offices or?
Hi, Diana Felton, Communicable Disease Public Health Nursing Division. So the offices, the public health nurses are in offices all across the state in different communities. We have 18 offices, and that's the main place where the utility shortage is occurring, everywhere from Lanai to Waianae to East Hawaii, West Hawaii, Waimea, all across the state. And
But these are buildings that is under you folks. We own those buildings. Or
most of the
offices.
buildings we own, yes.
Do we have solar systems on all of those buildings?
I'm not aware of solar systems.
Probably not.
I don't think
Okay,
so.
because it could help if it's our buildings, you should start considering solar so that you can have the utility rates drop as well. Just an idea. Thank you.
Okay, let's go to 131.
Okay. So for 131, the first ask is for our immunization branch, which we are again concerned because of the new administration. It is, I believe, 96% federally funded. And we have a program manager and a secretary that we're asking to be funded with general funds to ensure the stability of that program. Should funds be cut, those are the 2 positions that we would just like to make sure that we have present and that they feel comfortable that they're going to be continue to be paid should there be federal cuts. The second is for an epidemiologist 3. Basically, we have an ELC grant that's covering it up to 7/31/26. This is a cross-cutting epidemiologist, which is critical for helping with new outbreaks, events, or monitoring disease trends, and to reduce the risk of widespread outbreaks. The next one is public health veterinarian. We used to have a veterinarian, and with all of these zoonotic diseases that are occurring, we really believe that it would be helpful for the Department of Health to have a veterinarian that deals with human diseases as opposed to a veterinarian that's dealing with animal diseases. So that we think is important given especially the avian flu situation.
Which other states do that?
Excuse me?
Which other states do that?
A vet for human diseases.
Okay.
You have to speak in the mic. You can state your name.
Sarah Kimball, Disease Outbreak Control Division Chief and State Epidemiologist. So there are a number of other states that have a state veterinarian, dedicated state veterinarian. I would say the majority, but I can get the exact numbers for you and follow up.
Thank you.
And then the next one is for our public health administrator, which is Sarah's current position. However, Sarah's also the state epidemiologist, and it really is challenging to be the state epidemiologist who's dealing with all of these new outbreaks and making sure that they are able to provide support to all of the other Department of Health epidemiologists. So we're asking for a public health manager who basically can run the disease outbreak and control division. As you know, with the state, there is a lot of bureaucracy, a lot of administrative work, and we really need somebody that's just doing that work as opposed to, it would be a non-physician position. We do have a deputy that is a physician, so they would be kind of dual roles. We'd still have a physician in the position, but we would have a non-physician program administrator. Then for Family Health Services Division.
We'll do 420. I think they want to go in order.
Oh, okay. Oh, yeah, sorry. Go ahead.
Okay. Next up is 420.
We're focused on the neighbor islands, but also eventually would like to convert over for Oahu as well. This will expand the group of folks that we're providing services for, and it won't just be for the severely mentally ill population. It'll be for other folks, as Dr. Fink previously talked about. We're asking for a total of 68 positions to be converted from temporary to permanent. And let's see, and that's pretty much it for 420. We are also asking for funds for contracted inpatient services for neighbor islands. This is a contract that we have right now with HHSC, so that folks that are found mentally ill don't need to be flown over to the state hospital. They can stay on their home island. So this way, they can stay within the community, they can stay connected, and it's not taking the resources to fly them back and forth, since they'll always need escorts with that. For the hospital, again, continuing to look for efficiencies as well as making sure that we've got folks in the right beds. Two things that were not talked about were a building manager position and 2 investigators for the hospital. Building manager to oversee a lot of the construction and maintenance issues that are coming up with our Hale Ho'ola building. It's taking a lot of staff time to manage that and kind of coordinate with DAGs and the vendor to make corrections. And the investigators are to ensure that we do timely investigations when patient abuse or any other types of, I'm not going to say criminal, but administrative breaches occur. We want to make sure that we address those in a timely fashion. In 440, we're asking for funds to our overdose data to action program and to increase the federal fund ceiling for ADAD. And for 460, which is CAMD, we're looking for position and funds for one office assistant and transferring human services professional from one program ID to another. And then lastly, for our 501, which is DDD, we're looking to add position and funds for a federal initiatives operations coordinator position.
By 20.
That's it on BHA.
I don't know if you want to speak to a position for one disability program specialist.
Yes, afternoon, everybody. My name is Brian Mick. I am the Program and Policy Development Staff Coordinator at DCAB. Apologies that our Executive Director, Kirby Shaw, could not be here. But DCAB is asking for one new position. This is with an eye towards the new regulations that were issued by the Department of Justice, non-discrimination on the basis of disability, accessibility of web information and services of state and local government entities. So they will be requiring that websites, electronic documents, and mobile apps comply with these regulations by, in our case, for the state of Hawaii, the effective date is April 24th, 2026. So we're hoping to get a position that will be able to assist all the state agencies in complying with this and helping them as we move forward. Yeah. Thank you.
Thank you.
Okay, back to our family health services. So we came to you last year regarding a birth defects program that was funded with the it's a special fund that was funded with the marriage license certificates. It was determined it's really not an appropriate source of funding for this particular program. So this year we're asking for, and it's kind of complex. I'm not going to go into the details, but essentially taking it out of that special fund, funding it with this general fund. So that's what this particular ask is for, is to just remove that source of from this marriage certificate special fund and use general funds for it. For the next one, it is to convert 16 WIC positions from federal funds to general funds. And the reason for this is just, we recently had a potential federal shutdown. When that occurs, if we have offices that only have federal WIC positions, those offices literally have to shut down. Families who need food supplies or to apply for food, to determine eligibility, they can get these food services. They won't be able to access it during a federal shutdown. And so the purpose of having 16, which is just not the whole program, it's just 16 to be able to allow all of the offices to remain open. Right now, 14 of those positions are filled. We have 2 vacancies. If there is no shutdown, then essentially those positions, the funding for that can then be transferred to provide additional food. So the savings for that can provide an additional $842,000, which can allow for 3,000 additional eligible WIC participants from above the current average of 26,000 per month. The next one is for the reestablishment of our oral health program. It had been a program in Hawaii for a long time. I include how long we haven't had it, but Hawaii has one of the worst levels of tooth decay Hawaii has one of the worst levels of tooth decay in the nation, second only to Native American children. People don't recognize the importance of dental health. It has a lot of impacts on not only just the health components, people's self-esteem, as well as potentially cardiac problems as people get older. So we do really strongly advocating for this. What its funding is going for is 2 full-time positions, as well as to being able to provide dental sealants in school-based programs. So we would do screenings as well as providing dental sealants, which makes it a lot easier for these kids to have preventive work
So this is statewide,
statewide.
all schools.
That's my just funding for
Public, or only public schools?
public schools.
Public schools.
No, but I mean, every public, so every elementary or every middle school or.
I'm Matt Shim. I'm the Chief of the Family Health Services Division. We're currently working with Hawai'i nurses, but the idea behind this is to work with complex area superintendents each year, working on a different complex, and then creating a community-based school-based sealant program with the community health centers, working with the schools.
So not every student in public school is going to get covered the first year.
Correct. Correct.
What's the ramp up? How long for every school?
Well, if we, it would probably take about 15 years.
15
at,
years.
$500,000 a year. Obviously, we are not asking for services for.
So
every
which
single child.
ones? Because I think some legislators might ask.
So right now, what we're doing is Hawai'i nurses, I think, are in over 60 schools.
So how do we know which schools?
I have a list I can.
Okay, if you can send that to the committee.
Yes, I can.
Do you have the ramp up plan? Do you know which school?
I don't have a ramp up plan because we don't have a program yet.
They need the money.
So what are the 2 positions going to do? You have only
Coordinate
2 positions.
The 2 positions would be managing the program and creating.
Or restarting it actually.
Correct.
Restarting it and coordinating the.
Correct. And going after federal grants.
But if did you have an estimate of what it costs statewide?
For a total school base for every single child? No.
Well, the 155,000 in public schools.
No, I don't have that. I can.
Okay, so this doesn't include charter. This is only for complex area superintendents and the.
As a small beginning, yes.
What is the plan? What is the overall
Okay.
plan? And when you.
I don't think they have a white paper, sounds like, not a plan.
Yeah.
Well, we haven't had an oral health program since 2009. So we don't have staff to do.
No, I know. I
studies
guess what
or-
we're asking is, okay, what are we gonna get for this 567? So if you can just write that up.
Yes, I do have, that was actually presented in the Form A. So I have that. I have
With
a
the
budget.
schools?
I have a budget that was prepared for the Form A.
Yeah, so the 567 is gonna be which complexes? You don't know that yet.
No, we would have to work with DOE and.
Yeah, I think that's the kind of detail we're looking at. We want to know where is.
Are you selecting
plan?
It's wherever the taking nurses are.
It would either where the KK nurses are or are not.
Oh, it's also are not.
Yeah.
Yeah,
So
because
if they're not-
eventually this is statewide.
Yeah. We actually are in all
Yeah.
rural areas with the white KK nurses.
Yeah, Hawaii taking nurses.
Yeah, but not every school is gonna get covered. So if it's a 15-year ramp up, this is just a couple of schools every year.
Correct. It would be we'd be working to get a complex area.
And this is at the elementary school level, yeah? Yeah.
Elementary.
I mean, I remember it. You probably don't remember it. Troy doesn't remember it.
Remember them going to my school doing this.
We had it in our schools.
So this is a small ask to begin the program and to ramp up and to create a full service oral health program for the statewide. So we're asking for 2 positions.
Okay, if you can just give us.
Interested in it.
Yes,
So
If you
can
can
come
just
up
give
with
us a little, yeah, give us, because I want to see what that looks like. I mean, I think all of us would want to see how this would be rolled out. And if legislators made this their priority, how would that affect their district?
So right now, I can tell you, we would still continue to work with Hawai'i Keiki nurses and funding them to remain doing dental sealants in all their schools and expand the Hawai'i Keiki nurses.
Yeah, but that's 15 years is like a big gap.
Well, but that's if we only had $500,000 a year.
No, so that's-
and could only go
yeah.
to one complex area and create.
We want you to be more aggressive.
Yes.
Okay, but we can, we can follow
get that.
up. We can follow up.
Just-
Okay, what's,
Just to add, and thank you anyway, we're all happy
You
that
remember
this
this?
is proceeding. However, one issue that you're going to find working with the schools is that, is it going to be a place where they need a room? And just to add, because we've added more positions for preschools in the existing complexes and schools, they're all trying to find a place. So just to let you know that
Yeah.
there might be some problems putting a full-time person and where they're going to be located.
no,
So-
but this is not full time, right? Because, well, at least
Is
I
it
don't,
full-time or
what I
part-time?
recall was when you had one couple of days out of the year where all the students of a certain grade would get this service.
So it'll be good if you can
And they
do
just,
one, you can do a model.
borrowed the health room.
You can do a model and
Yeah,
pick a
the
place where
health-
there's a space for them to work at.
There's already a space
and
for the
then,
Hawai'i Keiki nurses.
I will work with the Hawai'i Keiki nurses because they're in all the school, or they're in a majority.
Okay, we all want to see what.
Thank you.
schools.
I did submit that in our oral health report, in our legislative report.
So you got two schools, so make sure one goes Oahu
Okay,
and one goes
we'll
to a
follow-
neighbor island.
We'll follow up.
Positions. not-
Thank you.
We will get you information.
Okay, next.
Out of interest.
Okay, we're very thrilled with your interest in this. Thank you very
No,
much.
I think most of us agree with what you guys said. I mean, it has a huge impact,
Exactly.
huge. Because we don't have fluoride, right? So that's why I think this kind of thing, you have to, yeah, you have to teach, and the habit has to be early.
Great. Love the support.
So that's where I would want to see if the stats showed, going back to, I think what the Senator DeQuette was alluding to was, if you look at the areas with the worst dental care, are we starting off with that? I'm not sure. I mean, just kind of layering this
I hear you.
with the stats.
Got it.
Yeah. Oh, they have.
Sorry.
Yeah, see, and at one point it was just sugar cane.
I'll do.
But you know what?
It is- that is good,
But
but
the plantations, every
It's fine.
school had a health director.
okay.
Okay, if I may, there was an ad, they put it under 560, this is $3 million, for reproductive health and planning services. Again, I think there previously had been some assistance, and some of this is also out of concern of what might occur at the federal level to ensure Hawaii residents continue to have uninterrupted access to reproductive health care. So that would be the $3 million for this. Okay, back to you.
Okay, so I'm not as familiar with these, six for my staff from CDPHPD. So basically, the under 590, we have 2 asthma program specialist positions. I believe that these are cost neutral positions, but it's
Yeah.
kind of complex.
Yeah,
shifting
it's one
things
for
around.
one. Yeah.
For
You guys can skip the trade-offs.
okay.
Great.
Let's see. I'm sure
596.
596. Okay.
Public-
So 596 is funds for relocation of our OMCCR program. They're located in Kaneki right now.
Medical cannabis.
Oh, sorry, medical cannabis.
Yeah.
So they are located in Kamiki in those rented units from the UH, and they're pretty much falling apart. They're very dangerous.
Where you guys gonna move it to?
So I believe it's one Kapilani, they found a lease,
The senior.
Oh,
no. It's a regular office. One Kalakaua.
That's what.
Yeah. It's one.
Not my
Kapil.
district, so I'm not that familiar.
And so they are looking to move hopefully within this fiscal year into that. And
And they have to pay rent then? We don't have space in the,
they've been looking. They've been
Dags
looking.
and-
Yeah.
Dags
I
told
I
us they
took to
have-
Dags, and this is one of the units that Dags.
They told us they have a whole floor. Anyway, we can. Okay, next then.
Okay. And then the other two are basically provider for educational campaigns. One is basically, we really need to educate our medical providers about how to utilize medical
Yeah.
cannabis. A lot of it's hard for our patients to find providers that are willing to issue those cards because they're not comfortable with it. So we wanted to establish an education campaign for providers to help them feel more comfortable with cannabis.
Yeah.
No, I just realized I was focusing only on Senator Dela Cruz and I thought spread my gauge across. That's helpful.
Oh,
When we get to our multi. Okay, and so, the other campaign is again with the potential for adult use coming on board. We also want to educate the public about what some of the risks are with using cannabis. So those are our two educational campaigns. Then we have, the next one is someone else.
Okay, 610.
Aloha, Kathy Ho for the Environmental Health Services for Environmental Health Administration. 610 is the Environmental Health Services Division. Kenny highlighted for us the vector control position. What he did not highlight is in 610, we're asking for one admin specialist and this will assist us in fiscal and HR matters. The other thing that he did not highlight is that we are asking for 6 food specialists for the food safety program in 610. In 710, Kenny has already highlighted for us the need for a clinical laboratory director. Thank you. 670.
So this is a new position. So you have a lab director now.
So we have a lab administrator.
So what's the difference?
And this, so what we're hoping to do with this position is,
more science.
the
The one is more admin.
one is more admin and one is more science.
Yeah.
And this is, they've done it in other programs where we have the administrator who administers the branch or division, and then we have a doctor who concentrates on the science part of it. So this is what we're looking for as we're moving forward in state
You
labs.
haven't had that before.
Never,
Hmm.
never. Okay, so 720.
So the first two are just transfer trade-offs or variances. The third one is to increase the ceiling for the civil monetary penalty funds by 250,000. These are funds that we receive when we issue fines for different nursing facilities for the skilled nursing component. So when they have deficiencies and they elevate to a certain level, we issue fines, and those fines then go through CMS and come back to us and into the special fund. This special fund has a lot of limitations in terms of what it can be used for. CMS right now limits us to $5,000 per facility that has an SNF, a skilled nursing facility unit. So what we're planning to do is they gave us a couple of options. And so one option that we're taking is looking at a nursing recruitment campaign. And really, right now it's very in the formative stages. We're not exactly sure how their campaign fits into ours. But the other component that we're really excited about and hoping to be able to do is implement a training program for nurse aides. So the CNAs that work in these facilities, many times we're finding is that they don't have the restorative skills to be able to maintain the functional abilities, and their quality of life then continually declines. So we're hoping to be able to utilize these funds to offer a state program where we offer training to the CNAs. We introduced it to HHS long-term care providers, and they seem to be very supportive of it. So we're hoping to be able to do that. And we just want to raise the ceiling to just make sure that we're going to have sufficient funds for it.
So this is not general funds. This is all from monies that you get from penalties.
Yes.
How many are you expecting?
How many what?
Like per year that you're going to try to train and recruit?
So the way we're looking at the program is being able to hire trainers that will actually go into the facilities. Because one of the challenges that we often see is that CNAs will get trained in a classroom setting, but they don't know necessarily how to apply it.
Because, Hawaii State Hospital, sounds like, they need.
They wouldn't qualify because they're not under CMS. So they would have to be an SNF facility that is surveyed by us, by CMS.
Yeah, but the nursing assistant sounded, it doesn't matter where. I think there's a shortage.
You're exactly right. And what we
statewide.
are looking at is I'm working also with Lori Tsuchida from DHS because they do the CNA training. They oversee the CNA training program. So we're also talking with them about how can we upgrade the level of skills of the CNAs coming out of these training programs to make sure that they do have adequate training to begin with and that there's ongoing training to address the needs that they have.
Especially rural areas.
This will cover rural areas. You're just saying it's not CMS. What does CMS cover then or not cover?
So CMS is the Medicare program. So it's any long-term care facility that has a skilled nursing bed. So those are the rehab beds when you come out of a hospital.
So what would it take to expand the program from? Just in general, getting more nursing assistants?
I would have to basically look at what the costs are because the first level of this
Okay, so this is more like a pilot.
Yes,
And then,
through these funds.
And then
yes.
if this works, then
And
you
if it
can
works, we're
expand.
hoping to be able to do it statewide. We would love to see it in every single facility.
Well, sounds like they need it though. Every neighbor island.
Especially rural.
So how does this work with the Medicaid monies?
These are Medicare monies.
Okay, so this is different then. Because the Arches and the foster community care foster family homes are always asking us for more.
Yeah, well,
monies.
that's kind of my point,
Yeah.
which is why if they can't scale it up statewide for all different healthcare.
Right, so those are community-based programs. This is really for.
But this can be a
facility-
pilot for all of these other areas
We
of
actually
healthcare.
have another track that we're trying to plan for the community-based programs to improve the training. And that's going to be through our regulations. So we're also looking at that as well through our, because you're talking about the community care foster care homes as well as the adult residential care homes. There are real big challenges there. It's very systemic. And so those are some of the things that we are systemically looking at. How can we approach it? First from what we can regulate and then with partnering with training organizations. So the other example that we're seeing a lot of is with like case management. So a lot of the training for these aides in these homes are supposed to be done by a nurse case manager. But the nurse case managers, especially if they're being funded by Medicaid, the nurse case manager is supposed to be doing the training for medications, for any care needs that are more nursing related. And they do it through nurse delegation. However, what we're finding is that these nurse case managers are not always going on site and doing the training and signing off on it and making sure that the aides are properly, can provide the care properly and on an ongoing basis. So now we need to go back and look at, because we do regulate the case management program as well, is what can we do to regulate that a little more stringently to make sure that the responsibility goes back to the person who's actually supposed to be doing the training and ensuring that the care is properly.
So they're not going over there. How do you think they doing like on certified training?
Well, what I'm hearing, so a lot of this we're just researching right now. We've been, interviewing all of our consultants and we've been trying to get a handle on what is really happening on the ground. And what we're hearing is that many of the nurse case managers, because of COVID, had gone on a kind of health module where they could call in, but they were supposed to have reverted back at a certain date and they did not. And so now we're really cracking down and looking at, okay, is everyone doing those visits in person once a month the way they should be? And are they reviewing all those skills that they need to be reviewing to make sure that the aides still have the competency to perform them?
But has it impacted it? Because I know the challenges that we were facing was the cost, and I believe Senator Inouye has a bill on some certifications that their constituents had to fly for 2-hour certification. Those costs mounted to just literally come there, review versus,
The nurses.
you know, we've just telehealth other stuff as well to, you know, you watch and you oversee,
Yeah.
you direct as the certified individual to certify the person that you're training as well.
So you're saying that the nurses were complaining that the cost to go to the homes?
Just in general, as we started to do certifications for other things, because the cost, so you flying out of Molokai, it costs you $240 round trip. 1 2 hour, you take on Uber or taxi to wherever you gotta go. So it's like the TWIC transportation, ID stuff or CDLs, and you go back and then you come back again to pick that up. Whereas they could just literally zoom you in. If you don't need the full on hands-on, it was a cost factor and then limitation on flight availability.
Okay, so I can understand where the cost factor would be for maybe some of the regulatory components, but I don't know that our regulators would, our nurse consultants would actually not be on site. As many of those situations, really, you need to be there to observe what's going on in the homes, and that is a
Oh,
challenge.
yeah, in that case, it's different, but you know, if you're doing the nursing certification.
So it's not the certification of the CNAs, it's
There's
a,
another issue, but we don't, that's a different department.
Yeah.
Oh, okay.
Yeah, but I'm aware of the issue.
Yeah. Oh, okay.
Yeah.
Thank you.
Yeah.
Thank you, Chair.
Okay, next then.
and then another one is for the funding for the contracted services that we use to certify our adult daycare programs and our community-based CCF.
Yeah.
Community-
Foster home.
Yeah.
I adjust it. I think.
Yeah.
They're okay.
Okay, yeah.
Let's go into 7:30. 7:30.
Okay, so 7:30 is emergency medical services, and again, Kenny did address the need for the contracted, collective bargaining increases. The first one that we're asking for is every island has a medical director that's funded at 0.35 FTEs. And the purpose for that is that they're supposed to be on call 24/7 to the paramedics on those islands. We have shifted the model. So one of the challenges that we're seeing right now is to hire a physician manager to oversee the emergency medical services branch. It's been challenging. And we see that many times, except in some unusual cases like Sarah and Diana, physicians don't often, and Kenny, physicians don't often make good managers. They want to practice.
They never do.
They really want to exercise their clinical skills, but they really don't want to spend the time dealing with HR issues, with budget issues.
You didn't mention the governor.
Oh, I'm sorry.
Yeah, so 4.
So-
You at least have 4.
So what we're trying to do is we want to change the position to be a program manager. So the branch manager is a non-physician, and we want to increase one of the medical director's position from 0.35 to 0.75 to be able to have that medical oversight within the branch. The 0.75 is because we need to give, it's probably going to be hard to find a physician and pay them enough that they're going to want to work with us full time. The 0.75 gives us the commitment, but still gives them the flexibility to do other things.
Yeah.
So I didn't see anything regarding funds for increasing 988, because remember we had the Molokai thing, and when we picked up 988, no one was answering.
Oh.
We lost Marion.
Right.
So are there additional funds that we could, so when we pick up 988, someone would answer, especially since it's supposed to be a federal program?
Right, so 988 is the federal number, and they are unable, or they actually just implemented geolocation so that we will get numbers based upon location rather than area code.
Okay, I remember when we were in Molokai.
Yes.
You guys didn't have people who would answer 988 because the people had regular jobs and would only be able to answer off hours, which didn't make sense.
Yeah, no, because we have a contractor to do Hawai'i Cares, and that's the 808 phone number that we've had for close to 20 years.
So you guys
For
gonna be able to
emergency.
help out
So that should not be an issue at
Anymore?
all. 988 has been experiencing some trouble, and that's why we've always encouraged everybody to call the 808 phone numbers, because that'll come directly to us.
So we don't
Yes.
use 988 anymore despite the.
No, 988 is still out there, and that's the national number so that everybody knows 988. If you're in crisis, you can call.
We're down. I remember going to
Uh-huh.
you
So it
showed us
goes
the
to
able way that
988
there's
first.
people answering the 988 calls.
It goes into 988, and then from there it goes into Hawaii Cares. So I know that we've been having trouble with 988, and then for them to transfer the calls over
That's all federal monies is what
the
you're saying.
988.
You cannot just go direct 808 then if we gotta.
And
Yeah,
that's why we
she
encourage
suggested.
everybody to call 808 number.
Straight up
No,
808, what is that?
Well, yeah, what is that?
What is
number?
the number?
It's a 10-digit number.
Yeah, it's
Is it 808, 555 or
832 3100.
Wait, can I?
So we don't do 988. Yeah, clarify, because
Okay.
we got a whole federal.
Where does, when you dial 988, who does it go to?
It goes to a central location on the mainland.
Really?
And-
I thought, what about those, remember you gave us a site visit over here?
Yes, yes. So
That's
it
Holy
goes-
Cares.
So 988 is a central federal number, and based upon it previously, based upon the area code, it would go to a central location and they would respond there. And then they would forward numbers to us.
Okay.
So they've figured out the geolocation now. And so the numbers are being able to be forwarded to us based upon area, not just area
So
code.
are they currently automatically, the 988 calls, are they currently automatically being distributed to the Hawaii Cares
Yes,
operators?
yes.
So that situation on Molokai is resolved.
It should be resolved. So if it's not, I'd like to know. No, I haven't heard any complaints about it. So if it's not, I need to hear.
One number for complaint too, because we're going 980 and nobody answering that. Can you like this off? You doing like right up
It's
for
gonna be over here.
Sure.
step one,
You said it-
down here, step
Yeah.
two goes there, and if it doesn't, is it there a direct number to the 808? Which would be
Yes.
much easier for us to just
Yeah.
push out.
Yep.
But harder to remember.
Yeah,
Yeah,
Which is why we stuck with the 988.
you're right.
Thank you.
okay,
Okay,
disappointing. but
sounds like an
let's
info briefing in Health and Human Services.
move on. We did one, and it was supposed to be the catch-all.
Yes.
98.
My last one is the Molokai ambulance. Yeah, the last one, Senator.
Oh, yeah,
is
and
for
that's
the
what he mentioned.
Molokai ambulance,
Yeah.
for recurring funds for.
Yeah, because it was in a bill. Yeah, so now it's,
He's under the weather, so I'm just trying to.
Sorry.
oh, she can handle.
Cato, Deputy for General Administration. The next category has to do with our vital records. And it's tied in with our potential move from Kinahaale. So this first request is for moving an office space lease rent to move our vital records from Kinahaale to another location that's accessible to the public.
Where?
No, we gotta to be determined, because the site that we're trying to purchase or are going to purchase, unfortunately, DOH is not gonna be able to move most of their functions there, so it's gonna be DLNR that's gonna cockroach it now. And it wasn't even for them, it was for DOH, but
We tried.
yeah.
And this is one segment of the staff that's at Kinahaale. We basically have three different segments. One is our vital records operation that's needs to be accessible to the public.
Yeah.
The other is about 150 people who are part of our general administration. And then there's another 150 that's part of different programs that we have at Kinahaale.
Yeah, that's part of the morale problem, I think, that building.
Yeah.
I mean, it's
over
so
here.
old.
Yep.
It's restrictive,
Can we grab part of your parking lot for resources?
Yeah.
Yeah, it's unsafe.
We've been doing ongoing air quality tests for the building as well. So it's really important that we move forward with redevelopment of that property and moving our
Yeah.
staff out.
There was a request for planning money to start the process of knocking that building down last year. The money was restricted. As my understanding is it was restricted. But I don't see it in your CIP request table.
So it's included in part of that 3.75 million in 907. If you go to the end to 907,
For
part of it's planning.
Okay, thank you.
Yeah, but last year the monies for the Hawai'i campus was a legislative ad.
Yes,
This, you're putting in money for planning, right?
correct. It's for,
But-
it's
So
for-
the restriction also jammed up the timetable because the Hawai'i acquisition needs to happen right now. And
No, but I thought we
the
have,
Kinau transition is going to be delayed by at least a year because the planning money was restricted.
yeah, so we have to find, we have to figure out something in the next couple months.
Yeah.
Yeah, but it's all lead and asbestos in there. I mean,
Yeah. We passed that money out. I mean, that building got
yeah,
fixed.
anyway,
Gotta fix it.
we have to, we'll find, if not, I know a property in Wahiwa.
I can take over the office.
Okay,
And our second ask for vital records is for a position that had been defunded in the past. We do have an incumbent that's in that position and we're asking it to be refunded. That's it.
thank you.
So 840 is Environmental Management Division. Kenny has already provided you a summary of those that we are asking for, which is the program specialist for solid and hazardous waste to do source reduction, recycling and sustainability. 2 positions in the clean water branch for enforcement. Wastewater branch, we're asking for a engineer and a accountant to assist us with the conversion. And then we're asking for 5 positions in clean water, 2 of which will go to the neighbor islands of Maui and Kauai for enforcement and inspections and monitoring. What he did not mention is something very small, which is to adjust the federal funds appropriation ceiling due to an increase in federal funds and methodology. Thank you.
Good afternoon, Caroline Kadirao with the Executive Office on Aging, and we have 3 line item requests in the Department of Health budget on page 38 under HTH 904. The first is asking for 1 position and funds for a program specialist 5. This will be for our advocacy, education, and outreach section under the State Health Insurance and Assistance Program. And that's to expand outreach, education, and one-on-one counseling to Medicare beneficiaries. Our second request is to convert the long-term care planner position from temporary to permanent. And our third request is also a conversion of 3 program specialist positions from temporary to permanent to support the advocacy, education, outreach section for the Senior Medicare Patrol.
So just, so you have incumbents in all of these positions that you want to continue?
We're still working on getting those positions filled, but yes, we're getting there. Right. Yes.
Thank you.
Thank you.
When was the last time your statute was updated though? Yeah. Oh.
So, sorry.
Wait, question for Carol. Oh.
Yeah.
Next one should go.
The HRS 349, we updated when we did the conversion and combination for Kapuna Care. I think that's section 32. And I believe we also had an update to the long-term care ombudsman about 6 or 7 years ago within the statute, within that section.
Because there's other areas that we've discussed at some of our WAM info briefings that probably need
Some updating.
well, not just updating, but maybe to be included.
Mhm.
You know, like we need to have more advocates for senior housing, safe routes from senior homes.
Mhm.
You know, we have safe routes to schools
Right.
program, but then I know of a lot of senior homes that there's no sidewalk and they can't get to the bus stop. I mean, there's lots of different components that
And
senior housing within the transit-oriented development.
And Senator, to answer that, I think what we'd want to look at is probably expanding section 349-4, which I think calls for a master plan on aging. And that would take into consideration housing, transportation, all
Yeah.
of those various
But even just being
factors.
more of we need somebody, because even when the different councils pass certain zoning bills, community planning, I don't think senior housing,
Is considered.
yeah, it's
yeah.
not really a priority.
Or
And
it's
then
an
you want to make
afterthought.
sure that the commercial and some of the recreational is in walking distance.
Right.
So that
Walkable
has to be. Anyway, I don't find that there's enough advocacy in that area.
Okay.
But we have such a huge shortage for senior housing, I mean, for housing in general,
Yeah.
but yeah. Anyway, well, I look forward to see what you guys come up with.
Okay, thank you.
Thanks. Aloha. Aloha.
And happy 2025.
Happy New
Strip
Year.
is really having quite an interesting year this year. We were fortunate to partner with MQD and apply for the AHEAD grant, federal grant. So, and we're recipients of that grant. So the intention is really to transform healthcare at the state level to give states the opportunity to solve a problem the federal government has struggled with for so many years. And it's going to be very exciting. It's a 10-year grant. It does bring us 2 positions, and it brings the state of Hawaii over the first 5 years of the grant operation, about $12 million for planning, for actuarial expenses, for data acquisition, for a number of things. But what's really kind of amazing about this grant is that it could bring $150 to $200 million a year to Hawaii, paid directly to hospitals, clinics, physicians, practices, and other providers who participate in the grant. And those monies don't flow through the state; they go directly to those individuals and clinics and hospitals as incentive payments for participation. So it's a real opportunity, and we're grateful about that. But there are a number of other things that are important to all of us in terms of the future of health and healthcare in Hawaii that the grant doesn't cover, which is what our requests are about here today.
Wow.
We're adding a position for an administrator in our office because we really have no one to help us with the HR and all those sort of functions. So we really need that position greatly. We would hope at some point later also to get an epidemiologist on board, not in this request today. And that is because the all payer claims database, which is collecting all of the data from the people of Hawaii, hospitalizations, outpatient visits, emergency visits, all of that data from all the insurers, thanks to your wisdom and granting the authority to create this database, it will become live in May or June of this year. So that's going to give us a chance to really to understand how we're doing cancer, how we're doing in heart disease, how we're doing in any particular area by population, by region, and it's really an exciting notion for us. So we'll come back to you about that particular issue. Now, I just want to mention one other thing that has just kind of looming has come to me, and that is that Medicare, as a federal payer, is underfunding this state in a very, very severe fashion. All of our hospitals are suffering under Medicare reimbursement at this point. We're doing better, ironically, in Medicaid funding for hospitals and for providers than we are in Medicare. And we've got to do something about that because the formula for Medicare, is determined by Congress. It's going to be, this is not an easy task to take on getting Congress to raise the formula, but we are the highest cost state, highest cost of housing of all states, and we have the lowest per capita reimbursement of all states in Medicare. So something has to happen. This is absolutely not right. It's just a formula that needs to be adjusted somehow. And I have some ideas about that, which will bring to you at a later time in terms of how that could happen. But this one position is just going to help us just get our work done with my lack of knowledge of the human resources, purchasing, and administrative functions, despite my years as Director of Health.
Thank you.
Thank you, Jeff.
Next number, what is that, 907?
So 907 is our general administration. I think Kenny's covered a lot of it.
Yeah,
I do want to
covered the ones that, yeah.
I do want to emphasize our request for our HR positions, the 4 positions. We are taking on more responsibility, especially with our hire project.
No wonder you're sick.
Well, we're really working hard to do more recruitment and get positions filled as soon as we can. It's difficult. Right now, we have 2 HR in recruitment that are working on it. And I think we would really appreciate additional assistance in filling our positions. Yeah. Okay, so we did a quick study. It's a little scientific, but not hugely scientific. But we looked at the number of HR positions in other departments and then looked at our department and saw the ratio between the total number of employees and the total number of HR positions. And we found that of the large departments, we have the worst ratio of all executive departments. This means that our people are working to service more staff in the Department of Health than in any other department of our size.
Your hire pilot project include this additional staffing for HR?
So the challenge with the hire project is it's just additional responsibility with existing staff.
So these 2 would be for that.
So asking for the additional staff will allow us to better resource,
Yes.
our recruitment activities. Yes.
Because we are seeking additional delegation for our own hiring. And it does take more for us to establish positions and reclassify positions when we have so many. So this is part of the ask to help the department fill vacancies. And our hope is that this will help the entire department move forward.
Okay, is that it? Any questions?
Questions on the CIP table?
Oh, okay, table. Okay,
We get it later.
15.
Thank you, Chair. Director Fink, I want to thank your deputy directors, Ho and Kato, as well as Administrator Seto for touring the DOH campus in Pearl City.
Thank you for coming.
So I appreciate that. I noticed in this CIP request, there's nothing that deals with the roofing issue there for your state lab. Do you have funding for that?
For the state lab, and we're talking about the CFP, the plan.
Yeah.
You're talking about.
Right. We did get funding for it last session. So we do have some monies for it.
And that it also includes the backup generator, right?
Yes. So we did get money, I guess 2 years ago, to also do a BSL-3 lab outside, a standalone building. That looks like it might not happen because of contracting issues. And so we might have to bring those monies and redesign our current lab. And that may mean that we'd be asking you to redirect that money so that we can use that money to,
So when are you gonna know?
Yeah, so we won't be asking for new money.
No,
We're
yeah,
trying-
no, but when
Yeah,
is, that has
Yeah,
to be a,
I think we're
Can you do
there.
that?
We just need to get
there.
in alignment with DAGs.
is it something BNF and DAGs can do in administratively, or do you need the legislature?
You know, we're still seeking clarification. That's
Okay.
on us.
Okay, well,
Yeah.
you're gonna let them know.
Yeah, please let Senator Aquino and myself know as we both represent that area. So thank you.
Great, thank you, thank you for your support.
Yeah, if not, she'll follow us. She'll hunt us down at the elevator.
Yeah.
That's how the money was in last year.
Or she just shows up in your office. I do have a number of questions.
Okay, go ahead.
Or at your house.
Okay, so, and I apologize if it's not a part of your master testimony, but it looks like that there was some monies on as HTH 215 that was part of HHSC, where there was monies for Department of Health giving monies to HHSC for Leahi. Are you folks able to get those contracts in, Marion? Because, I mean, I'm getting cross messages here. I mean, we had Johnson on that earlier saying that there's patients going, transferring, and Dr. Finn telling me no, and.
So we, for the record, we have transferred one patient.
Only one?
So I don't want to suggest there are no transfers. I think everyone is working in good faith to reach an agreement. There are some patients that we tried to transfer that they did not accept. But they did accept one patient.
Because they're asking they asked for $8 million in the fiscal year of 2024, and then another $14 million. And it says specifically request provided general fund appropriations to Oahu region due to projected budgetary shortfalls due to the due to the transfer of patients. So
what
it seems like a lot of money
Yeah, what I can say is in our budget.
for one patient, or
Yeah, well,
$22 million for one patient's a lot of money.
In our budget, so we have agreements with HHSC to provide services on the neighbor islands. Kona, Samahalona.
This is Oahu region.
Yeah, I can't really speak to that because again, they don't really care for many of our patients.
Okay, so we'll go talk story more as to why they're requesting so much money regarding patient transfers, and you folks just said one. Sean Sonata said more.
Well,
and there seems to be a
yeah, I can't say if that's just
because you guys are talking about a huge overflow of capacity in Hawaii State Hospital.
So yeah, so I can't speak to transfers from other hospitals. So I don't know it's what they were referring, but from again looking at, and we just checked this, we low single digit transfers.
Okay, Senator Keohokalole.
Not a budget question, but I don't want to jump to conclusions.
Yeah.
There are no eggs at Costco, at any Costco store on Oahu. Is that because of this avian flu situation?
So I think it has been reported on the mainland that where there have been outbreaks. The number is actually on the CDC website of the number of chickens that have been culled as a result of infections through farms on the mainland. And it is my understanding that it has impacted egg supply. To my knowledge, there's been no report of infection of a poultry farm on Hawaii. So local supply should not be interrupted. Eggs, that are cooked, chicken that is cooked is safe. And I'm just remind folks that while we are testing milk, there might be raw milk. Should it be coming into the mainland? Raw milk is not considered safe. Eggs are safe.
So I buy eggs at Costco. This might be a trivial thing, except if you buy eggs at Costco, which is a lot of people. They sell local eggs at Costco. And so I'm just wondering if vector control or whichever division is on this has been in communication with our retailers, because to not have any eggs for sale at any Costco on the entire island of Oahu is a big deal.
Yeah.
And I'm just wondering, I haven't gone to any of the other grocery stores, but just happened to be at 2 different ones in the last 2 days. There's nothing. And so I don't want to create an undue panic if there isn't one, but people are asking these questions already. If they, I mean, how long are we going to go where it's going to be like this? And are the other grocers or suppliers going to take similar sort of, how long is this going to go on?
We will look into the situation. Again, if this is an opportunity just to reassure the public here, again, there have not been any cases yet identified of poultry farms that have been infected. Local egg production is safe. And we'll see if we can reach out to Costco to understand what their situation is.
I think that would be their request before this goes on long enough that the public starts to come to their own conclusions about what's going on.
Yeah, we'll do.
Because our constituents are, I mean, they are reaching out to me about this situation, but not necessarily as it relates to eggs. But if people can't get breakfast jacks, this stuff is going to circulate in the community pretty quickly, I think.
Okay,
Thank you.
Senator Hashimoto.
Thank you. Yeah, I was at Maui Costco on Saturday and I got one of the last cartons before I think they were going to run out too. So seems like a statewide.
On the Big Island.
Well, and we have really no producers on Maui either. But nevertheless, we'll change subjects. I wanted to ask. I know you gave us some really good stats on the Iwilei Resource Center. I assume that is the first floor of the Iwilei Resource Center.
Yes.
So have we moved fully into the entire center? Because I know there's a lot of very important spaces above there.
So I'll start handing over. So the for the first floor, which is the crisis center, the seclusion room has been completed. We are receiving MH1s that are being transported there. So that is good. We've been operating at the mezzanine level, the stabilization beds. So then it's those 2 stories, which are kind of affordable housing.
It's a gold mine of housing like
that we need to clarify some things with the city and do some improvements. I'll hand it over to Marion.
Okay, great.
So we have procured, we have a project manager that's overseeing the contractor. There are things that needed to be done to make sure that that area was safe, and also some things that the city did not yet do, like sub-metering, that we're getting done right now. We've put out an RFP for an operator for the housing, and everything should be full February 1.
Oh, so soon. Very good. So what mechanism are we using for people to pay for these units? Are we using vouchers, or are we is this something that you're just going to give out to people? Like, because it's full units. Like I toured the place.
So these are folks that are severely mentally ill.
Okay.
And so more often than not, they will be receiving a subsidy because they're not employed. So we'll be giving them.
What kind of subsidy?
Cash.
It's being Medicaid,
Oh.
be a Medicaid subsidy.
And that will
Because
cover,
Medicaid covers the housing.
And that covers the whole.
Does it covers the whole
So
thing?
it won't cover the whole thing, but a large part of it.
So where does the rest come from?
So we are providing support.
The DOH is subsidizing. And that's enough. So it's enough to cover utilities plus the operator.
Yes.
What does it come out to? 50-50?
So we don't know yet because we haven't been fully operating that facility.
Okay, well, we need to know, because I think we're very interested in the permanent supportive housing space. I think this is I've said for years that this was the space that I thought the city was just left empty for years. I thought it was crazy. I'm glad we're in there now, but I think if we can figure out how to make that work, I think we can duplicate it. It's just we need to know what you're doing.
Yes.
So I'm very curious on how that happens. So please keep us posted. But I'm
Sure.
glad it's February 1st. So thank you.
Okay.
Can I ask my,
Okay.
Lorraine question?
Okay, last question, unless anybody else has, you have one? Okay, go ahead first.
You know, on the recurring funds for the second medic station ambulance on Molokai. So you guys looking at coming in every year for those recurring funds for the second medic station, or?
No, once it's in the base.
Yeah.
So you guys going to
In the base.
Yeah, that's what, it's
Okay.
2 years.
Okay, so I have to
So-
clarify. And then I got a follow-up question on the Kalaupapa situation and the transition out, which I know I gotta meet with you on that with the public meetings. How are you phasing out that planned? Because I know you're asking for positions to fulfill until the last patient passes. Have that conversation been had with you and the Department of Hawaiian Homelands, as well as now the county wanting to take it under their wing from Maui County?
So we have been asking for meetings to brief you on basically what happened with our informational briefing to the community. One of our bills is what we refer to as our Colorado County transition or trigger legislation. And it's identified all of the different components needed to make that transition.
So this was a result from the site visit.
Yeah, of the questions that, yeah.
Right, okay.
So we've identified what we could and what
And it
needs to-
includes all 3 agencies or just Department of Health?
It includes Department of Health's legislation that needs to be laws and rules,
Okay.
statutes that need to be changed. But the process involved all 3 agencies.
So,
And they've also reviewed the legislation that we're proposing. So they are aware of all the changes. There's a timeline to it. And we did brief your staff. There were about 7 or 8 people there. It's all spelled out. Plus on our website, we show basically some of what that transition would entail. The final piece is really who takes over jurisdiction in the end. And again, that's really not our call. However, we have been in communication with Maui County as well as, we've thrown it out there back to DHHL. DHHL has not made a decision yet as to what they want to do, but it is their land as well as the LNR's land.
yeah, they own half.
So
So DHHL gonna do is they're gonna do a beneficiary consultation.
So they are
with the
doing their own
community.
beneficiary consultation, yes. They have
So
their own process.
my question is, what is the cost to put Kalaupapa and the facilities that was under your care back to where it is on the transfer, no matter who the transfer goes to?
Well,
So-
it depends on the building, right? Because
Right,
some
yeah.
buildings are like, they
That's-
can't
yeah.
save them. And others, we gotta try to
Yeah.
historic preservation. gotta get
Right,
it.
so at the current situation is that there is an agreement between, or at least, I forget what they call it, but an agreement between DHHL and a lease agreement between DHHL and National Park Services. And technically, the Park Services is responsible for maintaining all of the facilities, but their position has been.
Okay, but is that in that bill?
Yeah.
Is that is that action between DHHL and US Fish and Wildlife or next?
Oh, yes. Yeah.
Is that codified in the bill if it passes?
So yes, it identifies that relationship will remain no matter what, that lease agreement.
No, but in
is
the sense of who takes over the buildings.
No, if I may. So there's right 2 landowners, DHHL, DLNR. DLNR has a cooperative agreement with NPS to be able to, co-manage on their land. And DHHL has a lease for NPS to utilize their property and facilities. Should the county, as a government entity transfer, the landowners and their agreements with NPS remain intact.
Yes, the same.
So,
Yeah.
so the bill doesn't address those. Those have their own expiration date in like 2050.
No, but that was part of the conversation we
We had
is
when
that
we were
we
down.
have initially we had 3 different agreements.
Right.
Every agency was going directly to parks versus us having a state position.
So primarily, and I think it's through beneficiary consultation. DHHL is really the landowner where Kalapapa is located, as opposed to all of Colorado County.
Well, the current,
Current location.
Yeah.
So,
Current location.
so my concern is, and aside from DHHL, is what is our responsibility financially for the buildings that have been maintained in our possession under the state? Because I'm trying to figure out, will we be tasked with having to put those buildings back into play? Or like if the chair says, this building can no longer be salvaged, tell me which ones can, which ones is fully like gone.
But
So that
that's-
way we can kind of
should-
get
But
like,
we should ask that of both DLNR
Yeah.
and DHHL, because you don't necessarily manage you're not the property owner.
Right.
So was there any type of lease between DHHL or an agreement between DHHL and Department of Health? When the colony first got established? And was there a language in there for what Senator DeCoy is talking about as far as transition of property?
There is not. So there's not a formal agreement between
wow.
DHHL and DOH,
From that,
even from back.
so at that point, it could be on clean transfers. Here you go, knock yourself out.
So
so it's not determined, right? 'Cause
Yeah,
in a
that's-
sense
yeah,
where
yeah.
you could say, hey, there's nothing
there's
in
no
writing that we
agreement,
gotta
here you
give
go.
you the buildings in
That's
perfect
kind of what
shape,
I'm
we're
trying to
out.
find out.
I mean,
Is there
there's nothing in
financial
there that,
obligation?
Not with
Oh,
us,
okay.
it's the lease with NPS.
It's the lease with the National Park Service.
yeah, but because they're already assuming some responsibilities.
Yeah.
So the lease specifies that the National Park Service is responsible for all DHHL operations at Kalapapa.
But I'm talking about, like, for instance, the clinic,
The care homes, yeah. So the care home,
the one that you
Yeah.
showed us.
Yes.
Yeah.
yep, so eventual responsibility for the care home will likely go to NPS unless DHHL decides they want to use it for something. But we are currently in the process of upgrading it
Oh, okay.
and such.
So it sounds like then you're out. You don't have any responsibility of anything.
Transition.
Yeah.
Well, I
It's
think-
now between the landowner and
We will keep responsibility for environmental remediation.
yeah, but that's if they decide, because if they want to keep the building there,
Oh, so I mean, so I don't want to say we just wipe our hands and we're all done. So from a facility perspective, I think that really reverts to the relationship between NPS and their lease with DHHL. So from a facility perspective, but we still have responsibilities there, primarily from an environmental perspective.
yeah, but so if they want to keep a certain building,
Yep.
But if they don't, then you do the environmental cleanup.
I'm sorry, from an environmental perspective, we have some of our CIP ask. There's just the remediation that needs to occur in other places unrelated to the facilities, unrelated to the buildings.
So why wouldn't you just start doing that now?
That's where some of our CIP ask are for.
Yeah, because well, that's what we were asking
Yeah.
when we went to visit. Yeah,
Yeah.
because there wasn't any. Okay, well, that's good. That means you guys there's been follow up.
Are they gonna, I gotta, you're nice.
I still think we probably should do I don't know which committee, but they should do an info briefing.
On Kalapapa.
Yeah, and we can do another website visit after this.
Chair, he's the mayor for Kalawali.
That's right, you are the mayor.
I know a guy.
I know a guy.
Yeah, I'm still a little concerned in the sense where I hope the federal agency doesn't have three separate. I would rather have a state position so that we're not being over leveraged and we know what expenses are needed. Timelines are consistent, because that didn't seem to be the case when we went.
I think the only transaction is really the lease. I think the agreement, and I would defer to DLNR. I don't know that funds exchange hands. I don't know, but it's a cooperative agreement. The transactions really occur between DHHL and NPS.
Yeah, but there's still some, I guess, historical sites on the DLNR land.
Yes, that NPS maintains.
Yeah.
The National Park Service maintains as part of the cooperative agreement.
That they're willing, that DLNR's, because I haven't heard from DLNR if they're going to keep everything that's there.
They intend to continue the relationship with NPS and the facilities on DLNR land. They intend to continue that as it is now. So no changes.
And NPS manages that through federal funding. And, you know, that's the Father Damien
Yeah.
Church, and that is the historic.
Well,
you
and
know,
then there's still some resolved issues with where the monument should be.
So that's also on the DLNR land is where is
Yeah.
the memorial site.
So that's been finalizing, because when we went, it was still different possible locations.
Kind of up in there because of
Yeah.
that thing one trying to wipe that whole area out.
They're still working on getting the final permits, both the lease from the Board of Land and Natural Resources, and they need approval from the Secretary of the Interior on the design and location of the,
Oh, so so it's not finalized.
it is not.
but you
Yeah.
there are stats of our contract.
Yeah, but we are very close to completing the contract for the monies that were granted from the legislature in 2021, I believe. So the $5 million that was granted to build the Kalapapa Memorial, that money will be contracted and encumbered within the next month or so.
And it'll be released based on achieving those different milestones of getting the secretary approval, getting the lease. So there will be, I think, some initial planning money released, but they have to meet those other, you know, conditions to be able to access the full funding to build.
But the site that we saw, going back to what Senator DeGoy is saying,
The Baldwin home on the DLNR land,
No,
on
it
the
was-
Kalawao side,
yeah, it was where the old church was, right across the street.
across
Yeah.
the street, yeah.
But then wasn't there a village there and then it got wiped out, right?
Yeah.
And
So the whole peninsula was Native Hawaiian villages before it became the site, the local site for the leprosy colony. And the site where the intention for the design is intended was the boys' home at Kalapapa. And I believe there was also a Native Hawaiian village there prior to the arrival of the first displaced people there.
I'm surprised DLNR wants to keep those pilings there too.
The pilings at the site, I think because the Baldwin Home for Boys was a very historically important
No,
site.
before you get to that point where there was, I guess, an old clinic.
Oh, the old
where-
hospital.
yeah, where-
Also a very important historical site.
Yeah,
Yes.
well, and I guess it was once you go in, you don't come out.
That was definitely how people felt. It was also one of the first places where they did experimentation on people with Hansen's disease.
Okay,
Okay, can I
well,
ask
it should be interesting to see what the bill.
one last question? Mariam Suji, on your budget request from the governors, you asked for 1.696 million for 26 and 3.73 million for 27 for contracted service costs for inpatient psychiatric services. What inpatient psychiatric
On Big
services
Island.
on the Big Island?
So that's with HHSC so that we don't have to transfer folks over to the state hospital.
So you're contracting with like Dan Brinkman?
No,
Because on the
yeah.
Big Island and Kauai.
yes,
Okay.
over at
Because
Kona.
I thought, when I talked to Dan Brinkman before, I thought that the contract was with Hope Services. So it's with both of you folks?
So this is for folks that normally would be transferred over to the hospital.
Also South One, right? They call it South One, I think. Okay, thank you.
Okay, we're gonna adjourn and then members will convene at 3:10 and have judiciary. Thank you.
But it's not here.